hear us, please?
دكتور احمد تاج.
طبعا انا برحب بالاستاذ الدكتور سمير رفله، دكتور سيف بيه، برحب بحضراتكم ومشرفينا النهارده.
يا جماعه كوهوس
دكتور احمد. اهلا.
دكتور احمد. Good to see you. Hi. Are you ready? We can start now, دكتور احمد. طبعا احنا سعداء دايما بتواجد الاستاذ الدكتور احمد تاج، يعني one of the active cardiologists في مصر الحقيقه، a rising star. He's doing a good job في كل حاجه electrophysiology, heart failure. I have the pleasure that Ahmed is joining us today. Thank you very much Ahmed for accepting the invitation.
cardiovascular events. However, we should put in mind the jelly cat phenomenon, that we shouldn't go too low, either in systolic or diastolic blood pressure, to avoid that the mortality curve increases in a certain point, which is determined by some references as 110 over 60 or 65 milliliter. According to the guidelines, and just before the guidelines, the major antihypertensive medication trials reported that most of patients were on more than 2 medications to control their blood pressure. So if you can see all those big names of the big trials, randomized control trials in management of hypertension, many of patients were on 2 medications, others were 3 medications, and even 4 and more than 4 medications to control their blood pressure. So the concept of combination therapy was there. According to the European Society of Cardiology in 2018, indicated as initial therapy as an antihypertensive medication, and this is preferably includes AC or ARBIS plus calcium channel blocker or diuretic. In uncomplicated hypertension and many other varieties, you will find that this first line of management is almost fixed in most patients with hypertension. Early combination is important in patients with hypertension, just to reduce systolic blood pressure and diastolic blood pressure as well. The American College of Cardiology 2017 proved the same, that sometimes you need to start with 2 agents from the first line antihypertensive medications to control blood pressure properly. And if you go to the NICE guidelines, the updated one at 2019, which is the British version of antihypertensive medications for hypertension guidelines, you will find that you start with either A or C, which is A stands for AC or ARBs, and C stands for calcium channel blocker if patient not controlled, both if patient not controlled at thiazide or thiazide diuretics. If we go for Canadian guidelines of hypertension, those triple combination is indicated in patients with resistant hypertension. So third of patients with hypertension will be controlled actually on 3 or more patients in some population. If we go to the hypertensive patients uncontrolled in dual therapy, according to 2018, it's class 1 equivalence A. I hope you can listen to me. Can you hear well?
Yes, Dr. We can hear you.
Thank you. Welcome, Professor Miller. Thank you for being with us today. Adding a third medication as fixed bell combination therapy is important, as a second step if patients are not controlled on initial dual antihypertensive medication. If we go for valsartan as a class effect, ARBs are one of the best in reducing the onset diabetes mellitus in higher adherence due to less side effects. And valsartan specifically as a potent antihypertensive medication with double-digit reduction, especially in uncontrolled patients compared to other important ARBs like losartan and telmisartan. It's indicated in a variety of hypertensive patients with heart failure, with coronary artery disease, post-MI, diabetes, and even with impairment of kidney function. Even in era of COVID-19 pandemic, still it is one of the drug choices as there is no remarkable side effect like cough, which might confuse patients or even might transmit more infection of COVID-19 across patients. Valsartan, and because it's one of the oldest and potent antihypertensive treatments, was enrolled in more than 57,000 patients in different randomized controlled trials. As a gross evidence of antihypertensive efficacy, and even in patients with renal impairment, delay or impairment of kidney function, or to drop microalbuminuria, or to delay onset of diabetes, or to treat heart failure, or the patients with post-MI and full reduction of stroke and myocardial function in So there are large evidence that valsartan is effective in different varieties of patients with hypertension. Actually, the way the molecule of valsartan is synthesized, which is called the regular technique, the three scientists who invented this technique actually got Nobel Prize as 2010. If you go for amlodipine, is one of the important antihypertensive medications as a cornerstone of calcium channel blocker. It can reduce systolic and systolic blood pressure, reduce blood pressure variability, reduce target organ damage, liver disease, hypertrophy, and diabetic nephropathy as well. So it's one of the potent cornerstone management of hypertension as well. And if you move to hydrochlorothiazide, T is one of the important diuretics or thiazide diuretics that reduces systolic and diastolic blood pressure as well. So if we put all together in one bill, of course, this will be effective as antihypertensive medication. We have different patients profile who could benefit from valsartan or valsartan combination therapy with amlodipine or with hydrochlorothiazide or with both medications. So for newly diagnosed patients, you can start with valsartan hydrochlorothiazide. If patient not controlled, you can use valsartan and amlodipine combination. If not controlled, you can add hydrochlorothiazide. Macht trial at 2006, and for those who can speak German, machen means to do, Macht means done or in action. So Macht trial, and it was conducted in Germany at 2006, investigated valsartan in about 17,000 patients, and it was found to double-digit reduce systolic and diastolic blood pressure, and this was within 3 months periods. If we move to combination therapy of amlodipine, valsartan again is one of the potent antihypertensive medication, double-digit reduction, systolic and diastolic, and the higher the blood pressure, the higher the reduction you can get with amlodipine, valsartan with different concentrations. So blood pressure control rate was much more done and achieved of about 95%. And if patients are not controlled on monotherapy, you can add double fixed bill combination or triple fixed bill combination like amlodipine, valsartan, hydrochlorothiazide combination. If we have all those three medications together, you have diuretic effect of hydrochlorothiazide, you have antihypertensive effect of ARBs by reducing angiotensin or blocking angiotensin receptors, and then we have calcium channel blockers working on the arterial vasodilation. So the recipe of success of combination therapy that they work together in synergism and they work with different mechanisms of action on different levels of pathophysiological causes of hypertension, which is achieved actually with this important combination. You can see that double-digit reduction of systolic and diastolic blood pressure across different varieties of hypertension grades. We have in Egypt SMART trial led by Professor Adil published at 2020 this year, and you can tell this is one of the important studies done in Egypt with different groups of patients across Egypt. Again, double-digit reduction amlodipine, valsartan, hydrochlorothiazide combination therapy starting from the second week and maximum by the 12th week of enrollment. So about 80% of 10 patients reached the blood pressure goal, which is very good. About 95% of patients excellent, good, tolerable medications. So the conclusion that valsartan and amlodipine hydrochlorothiazide combination is very effective in reducing blood pressure in patients not controlled on mono or dual therapy. Compliance is important, and it's important when it's just one pill rather than two pills you are using, and less side effects as well. So when you use 3 drugs or 2 drugs together, you reduce the side effects of both of them because usually you use a smaller dose of each of those medications. So single pill combination, because it's one pill, it gives you some sort of psychological assurance that you are not using too many pills, like 2 pills each therapy alone. And this makes the patient more adherent to medical treatment. So patients usually tend to persist or single pill combination therapy rather than 2 pills each one separately taken, and this is one of the most important characteristics of single pill combination therapy in hypertension. So as regarding protection, valsartan alone or with combination was tested in about 57,000 patients randomized controlled trials. It was proven to be effective. It's proven to be safe, and it has different indications: hypertension in adults, hypertension in children, aging from age of 16 and up, patients with heart failure, post-myocardial infarction, and patients with impaired glucose tolerance, and diabetic patients as well. So my take home, Mr. Chairman and all other colleagues, there are so many combinations that you can choose from whatever you like, and those green combinations are the most preferred by the European, including valsartan and the hydrochlorothiazide combination, either 2 of them or triple of them, or even monotherapy as initial medications. And even the American Heart Association, American College of Cardiology, they recommended a triple therapy, including amlodipine, valsartan, hydrochlorothiazide in management of hypertension in dedicated patients. And again, this is the ESST guidelines highlights that you can use either valsartan alone or in combination in uncomplicated hypertension, coronary artery disease, diabetes, and chronic kidney disease associated with hypertension, and in resistant hypertension as well. So we have any of those 3 combinations. They are effective, tolerable, with good adherence and predictable response. I think I reached my end of my talk. Thank you very much, and once more, thank you, Professor Magdy Abdelhamid, for offering me this great chance to be with you in this scientific gathering. And I'd like once more to welcome Professor Abdelhamid, my mentor in electrophysiology, and our president of the ICRA group, and thank you.
Thank you very much, Professor Ahmed, for this elegant presentation. First of all, I'd like to welcome my dear professor, Professor Galad Saeed. Welcome, Professor Galad. Thank you for joining us today, Professor Galad. I'd like to welcome Professor Mirvat Al-Maati, the chairman of the working group of electrophysiology. And I had the pleasure to join this session with my dear friend, Professor Atif Al-Bahri, the vice president of IABA. And I think we have also my dear friend, Professor Yasser Saudi online. Dr. Yasser.
Dr. Magdy, I'm here.
Welcome, Professor.
Thank you for this kind invitation. Thank you, Dr. Ahmed, for this excellent presentation.
Thank you, Yasser.
Thank you.
I have a question, Dr. Ahmed. Yeah.
Professor Magdy, I'd like to welcome Professor Atif Al-Bahri and Professor Galad, because I didn't realize they are there.
Yeah.
So welcome all my colleagues and professors.
Dr. Ahmed, we know that combination therapy now is a cornerstone for treatment of hypertension. And although we have different available combination therapy, however, the non-adherence rate to treatment is low, and the studies demonstrated that within the first year after prescription of antihypertensive treatment, after 1 year, actually 50% only are compliant on the medications. Despite it is a single pill combination therapy, which should improve the adherence for therapy. So how can we manage this problem?
Yeah, thank you very much, Professor Magdy, for this important question and important dilemma we are facing every now and then in Egypt and worldwide, actually. I think there are 3 corner pillars of this problem. One of them is physician inertia. Sometimes physicians didn't tell their patient the appropriate health education regarding how to be tied to the medications, how to keep lifestyle modification, how to keep on medical treatment, for how long I will take the medications, what to do if I have some side effects. So this usually lead to patients to stop medications because they haven't been told about their side effects or how to continue in them. The second corner pillar is the social input of medical treatment. Sometimes people give their opinion even without asking them that stop the medication, your blood pressure is okay, so don't take it anymore, it was just a stress and so on. So I think the idea of 100 million wellness, 100 million صحة, I think it's a very nice one. We can through these programs introduce health education for patients to be kept on medical treatment appropriately because this is the only way. Health education, keep telling the patient that you have to be tied with your treatment, telling the patient about the side effects so they are prepared well for the side effects so they will not stop medication simply because of some side effects here or there. Professor Magdy.
Dear Professor Ahmed, hello, how are you?
I
have
thank you, Professor Atif.
I have a silly question, if it's silly. When you mentioned thiazide diuretics, many ask us while speaking in many lectures, you mean chlorothiazide or hydrochlorothiazide or indimamide or all the same is a dosage, the maximal dosage that can be tolerated by the patient. Can you give a hint for the word thiazide?
So if I can catch your question, it's asking about the appropriate dose of different hydrochlorothiazide or thiazide-like diuretics, the appropriate dose.
Yes.
Is it right?
Yes. Yes.
Yeah. The starting dose of hydrochlorothiazide, I'll start with it, is 12.5 and it's upgraded to 25 and in some trials up to 50 milligram. However, we have to keep an appropriate eye on potassium and serum creatinine and follow up appropriately. What's usually is given in somewhere between 12.5 and 25 milligram. This is a small dose, but still effective, especially when combined with the appropriate antihypertensive medication like valsartan or amlodipine or whatsoever from other antihypertensive medications. So this is as regarding hydrochlorothiazide. The maximum dose is 100 milligram. However, I myself, I have never reached this level of 100 milligram per day because it will be very high and side effects, especially electrolyte imbalance and dysglycemia and dyslipidemia and hyperglycemia possibly will be there. So 12.5 up to 25 is appropriate for hydrochlorothiazide. And as regarding indapamide, 1.5 is this what's available. Is available as single medical treatment, monotherapy, or conjunct with other calcium channel blockers or AC inhibitors. Chlorothalidone 25 milligram. This is not available in Egypt as far as I'm concerned as single pill combination, but available in some combination therapy. Professor,
you know, Dr. Ahmed, in the OLHAT study, the chlorothiazide, the chlorothalidone, how they take the study from it, it was not the thiazide what we use now. What's your comment about it?
Sorry, I can't catch your question, Professor Atif.
Okay. In the OLHAT study, they use the chlorothiazide.
Yeah, chlorothalidone, you mean?
The chlorothalidone, yes. And we have here the thiazide, the hydrochlorothiazide. There is, can we apply the same results with chlorothiazide?
Okay, you can tell me the answer before I can tell you, because I'm sure that you use it in your patients and you find them very well controlled. Yeah. They are all either thiazide or thiazide-like diuretics. Even in the NICE guidelines, they put that you either use thiazide diuretic or thiazide-like, which means the indapamide, and the results is actually equivocal for all the three ones.
Okay, thank you. Thank you very much.
Thank you very much.
Dr. Galal Said, Professor Galal Said.
Yeah, thank you, Magdy, for these meetings, and thanks, Dr. Ahmed. You know, in my personal experience, I write only ARBs if AC inhibitors cannot be tolerated. The AC inhibitors are much more effective than ARBs in controlling hypertension because they increase the kallikrein, which vasodilate. Personally, I tried all these RBs. They didn't drop my blood pressure. The only thing which dropped my pressure is lisinopril, the AC inhibitor. And so I advise people to start AC inhibitors, not ARB, unless the patient cannot tolerate it.
I can't say any more after you, Professor Galal, and I'm very happy that you have this
you are talking, there's a company to ask you to talk about valsartan, and so they are making it the best medicine in earth. And the best medicine in earth is AC inhibitors, not ARPs.
Well, there are some meta-analyses that they prove that AC inhibitors are better than angiotensin receptor blockers in reducing blood pressure, and there are some other meta-analyses that prove that ARBs are more potent than AC inhibitors in controlling blood pressure. However, your input is very appreciated, Professor Galal Said. Professor Magdy?
Thank you very much, Professor Ahmed, for your presentation, and thanks for Novartis for the symposium, and thanks for the dear professors and audience with us, Dr. Magdy, Dr. Ahmed, and we have to proceed to the next session. Thank you.
Thank you. Thank you.
Professor Samir.
We are having Dr. Lamia Alam and Dr. Samir Rafla on ground, Dr. Azza Atta, Dr. Maya Hamdi Said, Dr. Mirvat Abul Maati online.
Good morning or good evening. First, I'd like to thank Professor Magdy Abdelhamid for giving me the honor to participate. I appreciate and really happy to be with all this beautiful gathering. I have the program on the mobile. First, I am honored also to have Professor Lamia and Professor Magdy beside me. The first talk, management of atrial fibrillation in heart failure patients. This session is about atrial fibrillation, and it gathers 4 eminent speakers, and it covers very important subjects. In spite, we had many webinars about atrial fibrillation, but we always hear something new or remind ourselves with some important points. So the first speaker, Professor Ahmed Al-Damati.
Thank you very much, Professor Samir, for joining us today in this very important session, which is on atrial fibrillation. And I have the pleasure to co-chair the session with Professor Samir Rafla, Professor Maya Hamdi Said, past chairman of the Cardiology Department at Ain Shams University, Professor Mirvat Abul Maati, the chairman of the Electrophysiology Working Group, Professor Azza Qatta from National Heart Institute, and Professor Lamia, Professor of Cardiology at Ain Shams University, one of the experts in the field of electrophysiology. And today we have the pleasure that we have a distinguished faculty from the EC, Professor Tajana Putpara, which is chairman of the EC guidelines on atrial fibrillation 2020. So Professor May will introduce the next speaker, Professor Mirvat will introduce the third speaker, and I will introduce our distinguished faculty today, Professor Tajana Putpara.
So let us to start with Professor Ahmed Al-Damati. Professor Ahmed Al-Damati.
Good evening, dear professors and colleagues. It's always an honor and a pleasure to join this annual prestigious meeting. My topic today is about atrial fibrillation in heart failure, from medical treatment to catheter ablation. My name is Ahmed Al-Damati. I'm a lecturer of cardiology at Cairo University. I'll start off with a quick introduction about AF being one of the major causes of stroke, heart failure, sudden death, and cardiovascular morbidity worldwide. Atrial fibrillation is independently associated with a twofold increased risk of all-cause mortality in women and 1.4-fold increase in men. A minority of these deaths are related to stroke, while sudden cardiac death and death from progressive heart failure are more frequent. Evidence accumulated across the years, and this is an important slide that I've came across showing evidence along different axes of management of atrial fibrillation. So the green axis speaks about the preventive measures that we take to prevent atrial fibrillation, namely the use of beta blockers, ACI, ARBs, MRAs, and the prevention of atrial fibrillation in patients with heart failure and the reduced ejection fraction, till we ended with the stage of the RACE 3 study that we are going to talk about in a few minutes. The blue axis here is about stroke prevention. We started off with warfarin being superior to aspirin, and then we came across NOACs, which was proven to be non-inferior to warfarin, and we ended up by the fact that NOACs are safer and slightly more effective when compared to warfarin. The red axis here started off with pulmonary vein isolation as an intervention that can suppress atrial fibrillation. It moved along till we reached the stage that it is better than antiarrhythmic drugs and that it can be used alone to maintain sinus rhythm without resorting to lines and cafes and so forth. And we eventually reached the point where we used alternative energy for achieving pulmonary vein isolation, namely cryoenergy, which was proven to be as effective as radiofrequency energy. So this evidence made us reach the point where we have a 4S scheme for structured characterization of atrial fibrillation endorsed by the European Society of Cardiology, where you need to think about the stroke risk and figure out whether this patient is at high risk of stroke or not, given his SHADS score. You need to think about the symptom severity based on the EHRA symptom score. You need to think about the severity of the AF burden and what's its temporal relation to time, whether it's paroxysmal, persistent, or long-standing persistent. Last but not least, you need to think about the substrate. Is there comorbidities? Is there an atrial cardiomyopathy evidenced by atrial enlargement or atrial fibrosis that can be detected in imaging techniques, particularly cardiac MRI? And when you think about your 4S scheme, you then go to your ABCs where you start treating atrial fibrillation, A being a focus on the anticoagulation to avoid stroke, B being better symptom control, whether by achieving better rate control or adopting a rhythm control strategy, and last again but not least, treating the comorbidities such as hypertension, diabetes, hyperlipidemia, and obesity, which are proven to result in better outcome when they are treated. So focus on some treatment strategies. We're going to go ahead for the next few slides. The first strategy that I want to talk about is the rhythm versus rate control strategy. So the AFFIRM study is a time-honored study that laid the concept of the fact that rhythm and rate control does not make much of a difference. So in this study, about 4,000 patients were randomized to a rhythm control strategy versus a rate control strategy, and the primary endpoint was looking at the cumulative mortality. And in a matter of fact, the investigators did not find a significant difference between both arms. Actually, the rhythm control group had more hospitalization, more complications that are related to the adverse drug effect, and more torsade de pointes as well as bradycardias. So this concept is now challenged by more than one study, the most important of which, and the one that is pertinent to our presentation today, is a study that is related to atrial fibrillation and heart failure, namely the CASTLE-AF study. In the CASTLE-AF study, about 3,000 patients were screened for eligibility. The investigator ended up randomizing about 400 patients to two arms. All patients have to have symptomatic paroxysmal or persistent atrial fibrillation, impaired ejection fraction that is less than 35%, and a device that allow home monitoring, whether an ICD or a CRT defibrillator. The randomization arms were the conventional therapy versus the ablation therapy. The endpoint that was looked at was the all-cause mortality as well as worsening of heart failure and admission to hospital. The investigators found, so this is again one of the baseline criteria. We're going to quickly emphasize the fact that these patients had an impaired ejection fraction in both groups, so the median was 32 in one group and 31 in the other group. So in this study, the investigator found that the endpoint was significantly better in the ablation arm. The ablation, being a rhythm control strategy, showed a better outcome when compared to medical treatment. This data was proven to be significant also when the investigator looked at death alone or hospitalization for worsening of heart failure alone. Each finding was statistically significant, and the hazard ratio showed a better outcome in the ablation arm. So the investigator concluded that catheter ablation for atrial fibrillation in patients with heart failure was associated with a significantly lower rate of composite endpoint of death from any etiology or hospitalization for worsening of heart failure when this was compared to medical treatment. So this is another clue that we could be heading to the era of a rhythm control strategy, but not resorting to drugs that could have deleterious effects, but for a procedure that is effective and relatively safe. The CASTLE-AF study had its strong impact on the guidelines that was published in 2020 that stated that patients with paroxysmal or persistent atrial fibrillation and heart failure with reduced ejection fraction could resort directly to a catheter ablation if they would agree for it, knowing the benefits and the risks, and that's a class 1 indication. You don't have to fail an antiarrhythmic drug before going to the option of catheter ablation if your patient has a reduced ejection fraction and that is based on data from the Castle AF study. So the other strategy that we need to talk about in this context is the lenient versus strict rate control if you adopt to go for a rate control policy. This is addressed in the RACE2 study, which studied the lenient versus strict rate control in patients with atrial fibrillation. In this study, the investigators compared lenient rate control, which is heart rate at rest that is less than 110 beats per minute. In a matter of fact, most of the patients ended up having a heart rate less than 100 beats per minute in this arm, versus the strict rate control, which targets a resting heart rate that is less than 80 beats per minute and with moderate exercise that is less than 110 beats per minute. The investigators found no statistically significant difference in the primary outcome, which was a composite endpoint between the strict control versus the lenient control group. What is important to mention here, pertinent to this presentation, is that the investigators appreciated that patients with impaired left ventricular function have to be followed rigorously for deterioration of the left ventricular ejection fraction if they adopt a lenient control policy, being cautious about the development of tachymyopathy. The third strategy that we need to talk about here is the preventive strategy. Can we prevent the occurrence of atrial fibrillation? And the answer is definitely yes, based on the RACE3 study, which randomized patients who have early symptomatic persistent atrial fibrillation for either a conventional therapy or an upstream aggressive risk factor modification for 3 weeks prior to cardioversion. This upstream aggressive risk factor modification involved mineralocorticoid receptor antagonists, statins, ACE inhibitors or ARBs, as well as cardiac rehabilitation that involved physical activity, dietary restrictions, and counseling. Patients were followed along for 1 year, and a 7-day Holter monitor was performed at the end of the follow-up looking for atrial fibrillation. These are the baseline characteristics, and it's important to emphasize here that the left ventricular ejection fraction in this study was less than 45% in about a third of the population. When we looked at the outcome, the primary outcome, patients were sinus rhythm in 75% of the case if they adopted the upstream risk factor, aggressive risk factor modification limb, while 63% only maintained normal sinus rhythm at 1 year if they were in the conventional arm, and that difference was statistically significant. The investigators came up with the fact that upstream therapy, including treatment of risk factors and change of lifestyle, is effective in preventing the occurrence of atrial fibrillation, and it is feasible as well. Again, this patient population included about 30% of the patients in both arms having an ejection fraction that is less than 45%. So your patient with atrial fibrillation and heart failure would certainly benefit from aggressive risk factor modification and lifestyle changes in terms of recurrence of his atrial fibrillation down the road. The last strategy that I need to talk about here is immunoablation and implantation of a CRT, which is a strategy that we sometimes are obliged to perform when all other measures fail. So your patient had 3 AF ablation procedure, it didn't work, he is on medical treatment, and the maximum medical treatment possible, his atrial fibrillation cannot be maintained in sinus rhythm, and even despite the rate control medications that you are keeping him on, his atrial fibrillation rate is still high. So this is the kind of patient whom you could be obliged to use this strategy in. So this is looking at data from the Magdy CRT study, and we need here to look at the red line, the purple line, and the light blue lines, which are lines where biweekly pacing was achieved in less than 90% of patients of the time. Biweekly pacing was achieved in 91 to 96% of the time, and the blue line here, in which biweekly pacing was achieved in almost 100% of the time. And looking at the probability of heart failure and death here, you can clearly see that when you achieve biweekly pacing in more than 97% of the time in your patient, you would have the best outcome. The problem is sometimes this cannot be achieved in patients with atrial fibrillation only with drugs. This is a study here where the investigators looked at the total mortality as well as the cardiac mortality in patients who were in normal sinus rhythm, patients who were in atrial fibrillation. They had CRT, of course, all 3 groups had CRT, but they were treated with drugs, versus patients who had atrial fibrillation who were treated with AV node ablation. And you can clearly see here that the total mortality as well as the cardiac mortality was similar in the arms of patients who were in normal sinus rhythm and those who were in AF but they had AV node ablation. Patients who did worse were patients who were in atrial fibrillation and had only medical treatment to control their atrial fibrillation. This, of course, emphasizes the fact that rate control have many limitations in this group of patients, and you might not be able to achieve your 97% biweekly pacing only with rate control. So again, this is looking at the same data differently. So this is looking at the left ventricular end-diastolic volume and see how it behaves with significant reduction, denoting improvement in patients who were in normal sinus rhythm and in patients who had AV node ablation, while the group who had only drugs to control their atrial fibrillation did worse in terms of the reduction of the end-systolic volume. I will wrap up with a quick case. This is Mr. RS with the 65-year-old gentleman who has ischemic cardiomyopathy, ejection fraction of 35%, and the left atrium of 60 millimeter. He has an ICD for primary prevention of sudden cardiac death. He developed long-standing persistent atrial fibrillation that is difficult to rate control and caused recurrent inappropriate shocks from his ICD. So the question is, what would be the next best step on his management based on the available body of evidence? And the options are AFib ablation, AV node ablation, an upgrade to a CRT, or up-titrate his medications to the maximum tolerated doses, and perhaps add another one for rate control. The point is, all these treatment options could be used. You need to weigh the risk against the benefit of each treatment modality and to figure out what treatment modality would suit your patient. Several factors needs to be considered. Patient-related factors, the years that he has been in atrial fibrillation, the degree of myocardial impairment that he has, the size of his left atrium, which is a very important point that needs to be considered. You have also to consider physician and center-related factors. How much volume do you do per year in terms of atrial fibrillation with ablation? You need to answer this question. Do you think that with an atrial fibrillation ablation procedure, you can maintain this particular patient in normal sinus rhythm or not? If the answer is yes, perhaps going to a rhythm control policy using AFib ablation or medications can be resorted to, if not rate control, whether by medications if can be achieved, or with AV node ablation and CRT implementation, perhaps could be the only answer if this is the last resort. So as a take-home message, I want to emphasize that atrial fibrillation and heart failure very commonly coexist. Medical treatment and catheter ablation remains to be the possible alternatives of therapy. There is growing evidence that praises the future role of catheter ablation in maintaining normal sinus rhythm. AV node ablation and CRT implantation remains a possible alternative for cases resistant to medical treatment and AFib ablation. Good evening.
Okay, as long as we don't have Ahmed with us online, so we will hear a comment by Professor Samir Rafla regarding this presentation. Then Professor Rami Alam is going to moderate a discussion regarding this presentation with Professor Mervat Abu Maati, Professor Maya Hamdi Said, Professor Azza Kat. Dr. Samir, تفضل.
شكرا على التوك الممتازة. ليا كومنت صغير. If a patient with heart failure and atrial fibrillation reverts to sinus rhythm, I do not stop drugs that prevent recurrence of atrial fibrillation as amiodarone and digoxin, maybe with lower dose. Also, if the patient with heart failure and atrial fibrillation reverts to sinus rhythm, I do not stop anticoagulants, maybe with lower dose instead of 20 milligram, 15 milligram. I just want to hear your comment and comment of the panel on these two items.
Welcome, Professor Magdy, Professor Hani Ragi, Professor Mervat, Professor Az.
Welcome, Dr. Magdy. Thank you for inviting.
I would like first to thank Dr. Ahmed Damati for his excellent discussion, presentation, and he covered most of fields in management of heart failure. And my comment is that our point of view for management of heart failure in patients with atrial fibrillation, management of atrial fibrillation patient with heart failure has changed in the recent few years. Actually, a few past years we used to manage patients. If he has a paroxysmal EF, we give a rhythm control. If he has a persistent EF or permanent EF, we give just anticoagulation and rate control. But actually, this point of view was changed. And now we think in AF that it is a comorbidity in patients with atrial fibrillation, with heart failure, because the AF and the heart failure coexist together and like chicken and egg, which begins first. AF sometimes leads to myopathy, induced myopathy, and actually in patients with reduced ejection fraction, it exacerbates his symptoms and worsening the heart failure. Because the concept of AF is just uncontrolled heart rate. Atrial fibrillation burden itself, it affects the symptoms and the status of heart failure. Number two, the remodeling and the changes in the atrium affect the late phase of diastolic filling of the left ventricle. So the atrial fibrillation is not an arrhythmia with high rate, it is a comorbidity and pathology itself. That's why I have some limitation with the AFRIM study. Actually, I think the concept of AFRIM study now changed because of the recent trials, which studied the Cabana and the Castle trials. Cabana trials showed that atrial fibrillation ablation is not severe, is not inferior to the rhythm control in patients with AF and heart failure. And Castle AF, the most recent study shows that it is more effective than rhythm control to decrease morbidities and to decrease hospitalization and worsening of heart failure. Thank you.
We are seeing many patients with heart failure have an atrial fibrillation in the daily practice, and actually I see that patients are doing well with medical treatment, just rate control. They get worse only when the atrial fibrillation gets too slow, AF. But otherwise, so the question, if I have patients with heart failure and atrial fibrillation controlled on medical treatment and well anticoagulated, so all the question when I should think to refer these patients for the electrophysiologist to asking for ablation, according to the new studies which documented mortality benefit or outcome positive with patients who were subjected to ablation compared with medical treatment. So when I should refer the patients to do an ablation, I don't know the answer. Dr. Mervat, should you comment about this question when heart failure patients with atrial fibrillation should be sent for ablation?
Actually, from the first day of AF, because we can judge at that moment according to his left atrial size, the ejection fraction, and the duration of AF, if he will benefit from AF ablation. The situation is we get the patient in heart failure and long-standing persistent AF more than a year or 6 months, then we cannot do except rate control and anticoagulation. We have to get these heart failure patients early. First of all, to exclude that AF is causing tachycardia-induced cardiomyopathy. Second, in order to intervene with AF ablation, we want the left atrium to be less than 5 or maximum 5. As you saw, the case which Ahmed Damati presented at the end of his presentation, he's presenting a patient with 35 ejection fraction and left atrium 6. 6 is now we have a very high risk patient to take him to the cath lab to do him ablation with his huge left atrium. The size of the left atrium is one of the success factors in the results of the AF patient. The ejection fraction, the lower the ejection fraction, this is a risk during the procedure because the patient he will receive general anesthesia for about 2 to 3 hours. He will receive IV fluids because we use irrigated tip catheters and we use nowadays high power. So we use irrigation. The patient might receive 2 liters of IV fluids in 2 or 3 hours. So I prefer that when a heart failure patient gets AF, please send him to judge if he needs PVI, pulmonary vein isolation using the 3D electroanatomical mapping or not. If we get the patient with heart failure, and this happens especially in the rheumatic heart patients, those who underwent mitral valve prosthesis and they have a very high atrial fibrillation permanent AF and uncontrolled. This happens every now and then. In this case, if you send the patient with the uncontrolled ventricular rate from different medication, then we can do her AV node ablation and inserting a CRT. And nowadays they do his bundle pacing. We have few cases of his bundle pacing in Egypt. We did with some experts. But what we do for such cases is CRT, and we have a modification to decrease the expenses by using a dual chamber pacemaker, ignoring the atrial lead. This is in case of patient who will never come back to sinus, and we use the 2 chambers, one for the CS lead and one for the RV lead.
Thank you very much, Professor Mervat. And before Professor May will introduce a second speaker, I'd like to welcome Professor Tajana Butpara. She's online now. Hi, Dr. Butpara.
Good afternoon. Thank you for inviting me to participate in the meeting. That's my great pleasure.
We are delighted that you are joining us today. Welcome, Dr. Tajana.
Thank you.
So, Professor May, can you introduce the next speaker, please?
Yes, sure. Before I introduce the next speaker, can I have a next question for the previous one? Is there any work done with AF ablation and left atrial appendage closure in the same time? Is there anything?
Yes, there is. Yes, there is in the literature nowadays. They are presenting or doing research. We're doing AF ablation and closing the left atrial appendage at the same time. Yes, it is, but it is not yet in the guidelines. And also remember that left atrial appendage closure is only for certain patients who will not tolerate the oral anticoagulation.
Okay, it's my pleasure to introduce the next speaker, Dr. Ahmed Tajuddin. Dr. Ahmed Tajuddin is a professor of cardiology in Suez Canal University. He's also the vice president of the Ismailia Metabolic Syndrome Association, and he's an expert in the field of electrophysiology and devices. The topic will be about anticoagulation strategy in non-valvular atrial fibrillation acute coronary syndrome patients. Dr. Ahmed.
Thank you very much, Professor Maya Hamd Said, for introducing my presentation, and thank you for all professors and colleagues and attendees who are with us here once again in Cardiology Updates 2020. So my talk is about anticoagulation strategy of non-valvular AF in recent acute coronary syndrome patients. Again and again, thank you, Professor Magdy, for this very elegant collection of topics and international and national colleagues in cardiology for this very nice gathering. My focus on this topic will be adopted from the 2020 ECC guidelines for atrial fibrillation, which launched recently in European Society of Cardiology guidelines. What's unique about AF that AF patients, about 1/3 of AF patients have stable coronary artery disease or have some sort of coronary artery disease intervention in the sort of PCI or CABG. And if you go on the other side for acute coronary syndrome patients, we will find that somewhere between 5 and 23% of patients with acute coronary syndrome, they have atrial fibrillation. So there is some sort of interaction between acute coronary syndromes and atrial fibrillation. Incidence of AF in acute coronary syndrome ranges from 2 to 23%. The risk of new onset AF is still there, about 60 to 70% in MI patients. AF itself may be associated with an increased risk of ST elevation MI or non-ST elevation acute coronary syndromes. Overall, 10 to 15% of atrial fibrillation patients undergo PCI for coronary artery disease. However, AF patients with acute coronary syndrome are less likely to receive appropriate antithrombotic therapy and more likely to experience adverse outcomes because of that than ECS without atrial fibrillation. The important dilemma of patients with atrial fibrillation and coronary artery disease, either stable or unstable, is the balance between the increased risk of bleeding or increased risk of thrombosis, either stent thrombosis, coronary artery thrombosis, MI, or stroke. So it's important to balance the risk of bleeding, which might be fatal, to the risk of thrombosis, again, which might be fatal as well. So it's very important that the anticoagulation strategy to be tailored after comprehensive clinical evaluation of the patient. And what I mean by comprehensive clinical evaluation is evaluation of the patient himself or herself with other clinical profile, including socioeconomic status, presence or absence of malignancy, status of smoking, expected adherence to medical treatment, neurological status of the patient, renal function, other comorbidities. And this will give us some sort of insight about the bleeding risk and ischemic or thrombotic risk. So when we balance ischemia, thrombosis versus bleeding, we can appropriately and precisely decide the appropriate indications. Major bleeding simply can lead to mortality, crossing by inflammation, transfusion, reaction, stent thrombosis, ischemia, hypotension. And so this is very important when we assess patients for anticoagulation therapy post-acute coronary syndrome. It's important as well to assess the coronary stent thrombotic risk. That's very important. Insulin-dependent diabetes, troponin-positive acute coronary syndromes, presence of impairment of kidney function, prior PCI, prior CABG give us a higher chance of coronary thrombotic event. So There are three important steps: pre-procedural considerations when dealing with patients with AF and acute coronary syndrome, procedural considerations during the procedure itself, and post-procedural considerations. When we talk about the procedural or pre-procedural considerations, we have to define the appropriateness of PCI procedure to the patient. Is he in need for PCI, or medical treatment will be enough, or even surgery might be better? And we have to assess the ischemia versus thrombotic events and bleeding risk stratification. About the procedural considerations, for example, radial access is better than femoral access in terms of bleeding risk. Stent selection, because some new generations drug-eluting stents might need a shorter period of dual antiplatelet therapy or triple antiplatelet therapy. Post-procedural complications, putting an eye on the procedure and pre-procedural milieu of the patient, we have to recommend not to use non-steroidal anti-inflammatory drugs and to use some PPIs, proton pump inhibitors, because of GI upset. Close monitoring and always re-evaluate the bleeding risk versus thrombotic risk. So when we have important, appropriate data about all these three important points, we can plan antithrombotic management, either peri-PCI, post-PCI, including use of antiplatelets and oral anticoagulation. In this slide, you can clearly see different studies assessing different novel oral anticoagulants in patients with atrial fibrillation and acute coronary syndromes, as comparing DAPT versus DAPT, which means dual antiplatelet therapy versus triple anticoagulation therapy. And it's clearly seen here that in Augustus, for example, apixaban, there is less International Society of Thrombosis and Hemostasis major defined bleeding or clinically non-major bleeding, so it was less with that use. If you go for the dual with the dabigatran, it's less for, again, international ISTH major bleeding. For dabigatran, again, it's less for clinically relevant non-major bleeding. If you go for the rivaroxaban, clinically relevant bleeding was less when used that versus that, or dual anticoagulation versus triple anticoagulation therapy. I will not go through all the studies, of course, because of the time limit. However, there are so many evidence that, generally speaking, dual anticoagulation and antiplatelet therapy is still effective as a management post-procedure in patients with AF and acute coronary syndrome. This meta-analysis enrolled about 11,000 patients, and you can clearly see that favoring that versus TAT or triple therapy, so less major bleeding, less clinically relevant non-major bleeding, less intracranial hemorrhage, clinically relevant non-major bleeding, still less with DAPT. So all those important dots which reflects the primary outcome is favoring that dual anticoagulation antiplatelet therapy is still a safe and effective therapy. If we go for stroke, no major difference. For myocardial infarction, slightly higher in depth, however, not significant. Stent thrombosis, and it goes without saying that it's more in the depth versus triple antiplatelet therapy, and this is why for the first up to 1 week, up to 1 month, we have to use triple anticoagulation therapy, including aspirin, NOAC, or non-vitamin K anticoagulants, and B2Y inhibitors. So it's important to put all those data together, and for management of patients with non-valvular AF acute coronary syndrome or PCI, pre-treatment is important with B2Y12 inhibitors is recommended in STEMI patients or when coronary anatomy is known. It should be withheld in non-STEMI patients until time of coronary angiography or invasive strategy. If urgent PCI needed, administration of parenteral anticoagulation like low molecular weight heparin is suggested, with temporary withdrawal of NOACs. Where thrombolysis is considered in patients with ST elevation MI, the initial step should be to assess the anticoagulation status like INR or activated partial thromboplastin time or anti-factor X ASA in patients receiving NOACs. So the management of patients with AF and acute coronary syndrome PCI, thrombolytic therapy may be associated with increased rate of bleeding, of course, in patients who are systemically anticoagulated. A balance between intended benefit like large anterior infarction versus harm like intracranial hemorrhage is very important to balance the risk of bleeding versus the benefits of thrombolysis. In patients doesn't have evidence of therapeutic anticoagulation, systemic thrombolysis may be considered if no access to primary PCI facility. So according to the European Society of Cardiology guidelines, AF patients with acute coronary syndrome undergoing an uncomplicated PCI, early cessation of aspirin and continuation of that which is oral anticoagulant, and in case of non-valvular AF it would be NOACs with B2Y12 inhibitor, preferably clopidogrel, for up to 12 months is recommended. Triple therapy for more than 1 week up to 1 month should be considered when risk of thrombosis, stent thrombosis, more than bleeding risk. And this is the important recommendation box for patients with atrial fibrillation, including non-valvular AF with acute coronary syndrome, BCI, or chronic coronary syndromes. And the most important message here that triple therapy is indicated somewhere between 1 week up to 1 month, not longer than that, to avoid risk of, according to the bleeding risk versus the thrombosis risk. This important illustration, NOAC, usually in patients with non-valvular AF, should be continuing as long-term therapy for prevention of thrombotic strokes. B2Y12 should be up to 1 year after PCI. Aspirin should be somewhere between 1 week to 1 month. So all those are triple therapy according to the bleeding risk versus thrombotic risk. If patients are medically treated, definitely should be on anticoagulation. Better to be in NOACs if they are non-valvular AF with single antiplatelet therapy for about 6 months. We have to assess the thrombotic risk very carefully, including presence of diabetes, prior acute coronary syndrome, multivessel disease, concomitant peripheral arterial disease, premature coronary artery disease, impairment of kidney function, and this is very important to assess the thrombotic risk. Bleeding risk, especially with Hasbled score, as you see here, is important so we can balance bleeding versus thrombosis. Clinical setting is important, and strategies to reduce bleeding associated with PCI can be there if you have radial access, BBI, using in patients taking that or triple therapy, even administration of fractionated heparin, especially if patient is medicated with vitamin K antagonists, pre-treatment with aspirin only, and adding B2Y inhibitor when coronarotomy is known, use OGB2-3A inhibitors only for a bailout or procedural complications, shorter duration of combined antithrombotic therapy. So those are the clinical tips according to the ACC guidelines that could be used to reduce bleeding risk in patients with acute coronary syndrome and non-valvular AF. If we go to the American College of Cardiology, American Heart Association focused update on 2019, it's not that guidelines, same principle, using P2Y inhibitors with NOACs, especially in patients with non-valvular AF, adding aspirin for less than 1 month for triple therapy, especially in high-risk patients. So my take-home message, Mr. Chairman and all panel committee, it's very important to balance risk versus benefit. And I think this is the golden rule in general in medicine and even in life. So we have to outweigh bleeding risk versus thrombotic risk before tailoring therapy for patients. So there isn't single regimen that fits all. This is not present in medicine. Treatment should be tailored to patients. Patients with non-valvular AF and Cocker syndrome are at high risk of stroke, coronary events, and cardiovascular mortality. So this is why we have to give them anticoagulation and antiplatelet therapy, which could be tailored to patients according to their risk profile. Again, no single regimen that fits all. Each medication should be tailored to the patient. Randomized controlled trials promote use of NOACs or direct oral anticoagulants plus P2Y12 inhibitors yearly after acute coronary syndromes. We can add aspirin for less than 1 month if thrombotic risk is high. Longer course of triple therapy should be considered in patients with very high thrombotic risk or multiple stents, especially left main stenting and multiple PCI. Compared with triple therapy, dual therapy has been shown to be associated with reduced major bleeding and intracranial hemorrhage. This benefit is somewhat counterbalanced by high rate of stent-related ischemia, so this is why we can go for up to 30 days with the triple therapy. And in patients with non-valvular AF, it's safe to use NOACs plus B2Y inhibitors for 1 year, then you can continue with NOACs according to the patient status. And this actually my last slide adopted from one of the important reviews about how to deal with patients with AF and the coronary syndrome. So initially up to 14 days, NOACs plus aspirin plus B2Y inhibitors. Then from day 15 to 30, plus minus, you can use triple or dual, then dual to 1 year or double for 1 year, then just one NOACs indefinite. Thank you very much once again, and moving the microphone to Professor Magdy Said.
Thank you very much, Dr. Ahmed, for this wonderful and thorough talk, I think. I think we might have 1 or 2 questions or comments from the panel.
Yes, I have a question, Dr. May. Thank you very much, Professor Ahmed, for this highly informative presentation. My first question...
in this important activity. Thank you very much, Professor Magdy.
My first question, are we using the algorithms in the daily practice, especially bleeding risk scores? We have different risk scores for bleeding, Crusade, Hasplet score, or we depends on just clinical judgment regarding the assessment of bleeding and ischemic risk. The second question, if the patient developed GI bleeding earlier while he on triple therapy or DAP therapy, anticoagulation and clopidogrel, so how can you handle the antithrombotics and anticoagulation in such cases?
So both questions are very tough, Professor Magdy. Thank you very much. For the first question, actually we have to depend on the algorithms because it's very difficult to keep all algorithms inside your mind. And in certain algorithms, there are some few important notes, and sometimes they're written in very small font that you have to take care of. When you're dealing with females, for example, we're dealing with geriatrics, when you're dealing with patients at high risk of bleeding or thrombosis. So I would recommend, and I'm sure that, or I hope that most of us are using those important algorithms or diagrams that make life easy for cardiologists or interventionists or electrophysiologists to put a plan for patients in such complicated situation of acute coronary syndrome and non-valvular or even valvular atrial fibrillation. So it's important. It goes without saying that all of us, we have our mobiles, either SOS or Android, they all have systems that make life easy in having those important algorithms or just on your desk or office in the clinic or the hospital. So we have to use them actually. I myself, I do that, or I hope that I'm still using them at the moment. For the second question, life is important. Our main goal of treating patients is to keep them alive. So GI bleeding should be assessed very thoroughly and meticulously. Is it dangerous bleeding? Is it how deficit is between the initial hemogram or hemoglobin and the one after bleeding? We have to stop all medications at once until we stop the GI bleeding. It should be like a multidisciplinary team approach between the cardiologist and the GIT team, because they can give some medications and do some interventions which might stop bleeding on the spot. So I have to get one of those 3 medications out of this equation. It will be aspirin first, put it aside. Then you have either the B2Y inhibitors or NOACs. If the patient has active bleeding, we have to stop all of them. Of course, we can analyze to make sure that there is no thrombosis. A patient should be admitted first. We have to reverse sometimes the effect of some oral anticoagulants. However, the effect of B2Y inhibitors will stay for at least 5 to 7 days according to the half-life of the platelets. We cannot reverse it, but we can reverse the effect of novel oral anticoagulants. I know it's very costly, not available in all places, but at least we have to try. Then we have to encourage GIT interventionalist or with endoscopic ligation if there is any medical treatment with intravenous to stop the bleeding. Then when the patient is stable within 20 to 72 hours, we can reinitiate according to the clinical versus thrombosis. Professor Magdy.
Dr. Ahmed, with you, Lamia Alem. Thank you for your excellent talk, and I have one question. In patients with acute coronary syndrome or ST segment elevation myocardial infarction, if the patient developed atrial fibrillation in the first few hours after the event for the first time in his life, what do you prefer, both the revascularization or PCI, to start with triple therapy or dual antiplatelet therapy regardless its SHATS-FASC score?
Thank you very much, Professor Lamia, my colleague in the field of cardiology and electrophysiology. And this is a very tricky question, I know it is. If this in the first few hours, so probably is ischemia related. However, we have to assess the whole patient risk factors. If he or she is hypertensive, heart failure, aging, if they have previously from their medical records paroxysmal AF, we have to deal with this patient as having AF. If the first episode ever in life, within the first few hours of ischemia, so possibly I will not pay attention for that, and I'll follow the patient as per protocol without having AF. Sometimes the patient is already admitted in the CCU, we have the patient on the already in the CCU, he is monitored, so we know that if there is any paroxysmal bouts of AF or assess the AF burden or not. So if the patient after the first 24 hours or even 48 hours has no evidence of AF, so possibly this is ischemia related. Professor Lamia.
يعني طبعا النيو اورال انتي كواجلنتس كل يوم انديكيشن. انا يا دوبك الاسبوع ده نزلت مقاله اظن في الامريكان هارت قالوا ان هو ممكن يدوا زاريلتو في الاي اف مع بايوبروستاتيك مايترال فالف which is a really big improvement. لان انا دايما اسال اقول ايه المانع انها تتعاتى مع الفالف. فهم دلوقتي بداوا بالبايوبروسيسز والمايترال ولقوا النتائج احسن من الماريفان. وبعدين بالنسبه هو انا اللي انا فهمته بيتكلم على تريبل ثيرابي. ما نقدرش ندي تريبل ثيرابي اذا اديت اورال انتي دول وبلافيكس ما تقدرش تدي معاهم اسبرين 2 بس وهو عادل هنا اخصائي.
Doctor, we would like to welcome Professor Adel Atribi, the chairman of the working group of intervention, past the president of the Egyptian Society of Cardiology. Welcome, Dr. Adel.
Thank you, Dr. Magdy. Actually, the triple therapy, the new guidelines, the default strategy is only 1 week. triple therapy for 1 week, and then according to the level of risk of bleeding, then we continue or not. So I think by time aspirin is moving away from acute coronary syndrome, and I think it will also move away from a lot of indications of aspirin as long as we have P2Y12 inhibitors. So I think this is the option that we have now is triple therapy for 1 week only, and this is new because we used to 1 month and then stop.
Okay, thank you very much, Professor Ahmed. Now, Professor Mervat Abdelhamid will introduce the next speaker.
Yes, it's my pleasure to present Dr. Haytham Badran. Dr. Haytham Badran is a professor of cardiology and intervention electrophysiology at Ain Shams University. He is one of the stars and shining stars in the sky of electrophysiology in Egypt, in the Middle East, and in Africa. Dr. Haytham Badran will answer the question which you gave me, Dr. Magdy, about when to refer a patient with AF and heart failure for ablation. Dr. Haytham, please present your case.
Thank you, Dr. Mervat. Thank you, Dr. Magdy, for the invitation. It's my pleasure always to be in this prestigious meeting. I think after the previous presentation, my topic is very easy, and as an electrophysiologist, I would rather tell you that you should refer all the patients for AFib ablation. But actually, it's not very easy to answer the question, which patient should be referred to do atrial fibrillation, whether he's... Okay, perfect. Whether he's in a heart failure patient or patient with normal ejection fraction, of course. So at first, this is the dilemma, or this is the fight between the electrophysiologist and the general cardiologist and the internal medicine. Usually the general cardiologist, interventional cardiologist, and the internal medicine prefer to keep the patients on medical treatment and avoiding ablation procedure due to many causes actually. First of all, they are not very aware of the results of the atrial fibrillation ablation. They are not very aware of the complication. They are not very aware about the cost of atrial fibrillation ablation. But after the recent trials, the CASL-AF, the CAPANA, and a meta-analysis of the trials, we could see in the presentation that atrial fibrillation ablation is markedly better than the antiarrhythmic drugs to control and maintain the sinus rhythm in the patients, and also to improve the outcomes, including the hospitalization and mortality as well. So at first I will go through a resume or introduction about atrial fibrillation. Atrial fibrillation is a pandemic. Atrial fibrillation is the most common tachyarrhythmia encountered in the population, whether young or old, and it was expected to be something like 5.6 million in the United States by 2050 to have an atrial fibrillation. However, this prediction was at 2001. Later on, at 2006, they predicted that they might reach 16 million patients with atrial fibrillation in the United States alone by 2050. So for anyone who wants to work with atrial fibrillation, you will find plenty of work to do. I do recommend for the new cardiologist to have atrial fibrillation ablation as subspecialty, because it's coming, and it's coming strongly. So this is the prevalence with age. It might reach something like 10% in the population above 80%, and 1 of every 4 individuals of the middle-aged men and women will develop atrial fibrillation at some times in his life. So actually it's a pandemic. It's a major cause of devastating strokes, and the stroke of atrial fibrillation is very devastating. It's very massive and affecting a large size of the brain. Usually it's at the middle cerebral artery, of course. So it's a pandemic like the COVID we are facing now. So the management, as said by Damati in the first presentation, is it's only about stroke prevention. And then we have 2 strategies, either the rhythm and rate control. And Damati discussed some trials about rate and rhythm control. I will go rapidly through them. Of course, the atrial fibrillation has a mortality and morbidity risk with affection of the quality of life as well. Economic and healthcare burden from the disease itself and from the treatment of the disease. It carries a very large economic and healthcare burden, so we should individualize the treatment approach according to each patient and each specific characters of the health state of the patient. So the first question to be answered, whether the sinus rhythm and the atrial fibrillation has the same mortality and quality of life or not. So actually, at the beginning of 2000, 2002, we had a very large trial. It's called the AFFIRM trial, which was mentioned by Damati. And this trial showed that there was no benefit in the endpoints, which was the mortality or the composite mortality between the atrial fibrillation, the rate, and rhythm control. So after this trial, we had another 5 smaller trials that showed the same. There was no benefit from the rhythm control in comparison to the rate control in patients with atrial fibrillation. However, and it shows some mortality trend in the patients with who were denoted for the rhythm control. However, this was not true. I mean, sub-analysis of this study and closer look to this study will show something which is very interesting. At first, the AFFIRM trial, the most commonly used drug to maintain sinus rhythm was the amiodarone. This is the first point. The second point, it was intention to treat trials. Many of the patients in the atrial fibrillation rhythm control arm were not in the sinus rhythm, and they were atrial fibrillation. And so the maximum point or the maximum number of patients who were maintained on sinus rhythm was not more than 60% along the AFFIRM study as a whole. The second point, when we look at the cause-specific mortality, most of the mortality in the rhythm control arm was due to extracardiac causes, and it was mainly due to the amiodarone, because most of us know that amiodarone is very toxic with extracardiac side effects, including the lung, the thyroid, the liver, and the skin and the cornea as well. So, moreover, the age group of this study was very variable between the rate and rhythm control arm, with very variable symptom perception in the groups, and the patient's acceptance of symptom as well. Amiodarone was the most prevalent antiarrhythmic drug use. On the other hand, we had some smaller trials like the SAFE trial, which used sotalol to maintain sinus rhythm, and it shows marked improvement in the quality of life when the sinus rhythm is maintained with sotalol and not with amiodarone, of course. So theoretically, if we maintain sinus rhythm and not just intend to do it, and if we have therapies that carries less risk, we might speculate that sinus rhythm would be associated with improved survival as well as improved quality of life. But this was only speculation. But if you go to a closer look to the RACE, PAF, and DIAMOND, and also the AFFIRM trial, we can appreciate that maintaining sinus rhythm is associated with improved mortality, but not with the use of the antiarrhythmic drugs. And this is the sub-analysis of the AFFIRM trial. As we can see, the only thing that shows better survival is the normal sinus rhythm, but using the antiarrhythmic drugs was associated with increased risk of mortality. So if we can maintain the sinus rhythm with something other than the antiarrhythmic drugs, of course we can get some mortality benefit. So these are the factors that favor the use of rhythm control rather than the rate control. Presence of paroxysmal atrial fibrillation not persistent, newly detected atrial fibrillation, more symptomatic patients and younger patients less than 65 years of old, the non-hypertensive or without other comorbidities, congestive heart failure, especially if exacerbated or caused by atrial fibrillations like the tachycardia-induced myopathy, and without the previous use of antiarrhythmic drugs or previous drug failure. Which patient should we refer to the ablation? The patient selection as the primary clinical benefit from the catheter ablation is improvement in the quality of life. Of course, the symptomatic patient, the highly symptomatic younger patients, typically younger and with resistant or intolerance to the antiarrhythmic drugs, especially class 1, because going to the amiodarone as first-line therapy is not recommended, of course. The selection is also based on the presence of predictors of poor outcome, with ablation as the presence of concomitant heart disease, obesity, sleep apnea, as well as the variables could result in higher complication rate, as well as left atrial size, as mentioned by Professor Mervat Abdelhamid, the patient age and type of atrial fibrillation, whether paroxysmal or persistent or long-standing persistent AFib. So we can say that sinus rhythm strategy would be appropriate if the patient is highly symptomatic, the first episode has a reversible cause, younger age, symptomatic despite rate control, the tachy-induced cardiomyopathy, LV dysfunction, diastolic dysfunction with symptoms, hypertrophic myopathy or aortic stenosis where the atrial kick is very important in these patients, prior embolic stroke or TIA. And we have two strategies to maintain sinus rhythm, either ablation or antiarrhythmic drugs, but of course I will show later then how the ablation is much more superior than the antiarrhythmic drugs. And this is the safety trial which shows that sotalol is safer and can maintain sinus rhythm and it can improve mortality and quality of life in these patients. And this is group of studies I will talk rapidly. It's a meta-analysis of group of studies comparing catheter ablation versus antiarrhythmic drugs in order to maintain sinus rhythm. This meta-analysis was recently published at the Circulation Arrhythmia and Electrophysiology 2019, and it shows that in every subgroup in the heart failure and non-heart failure patients, in the even in the younger patients, the mortality, the cardiovascular hospitalization, and recurrence of atrial arrhythmia was much more superior in the ablation arm versus the antiarrhythmic arm, and it was more, of course, pronounced in the younger patients and the men versus the females. And this meta-analysis was including something like 18 study with more than 10,000 patients subjected to atrial fibrillation ablation versus antiarrhythmic drugs. So this was a scheme for management of atrial fibrillation to maintain sinus rhythm. If the patient has no or minimal structural heart disease and his paroxysmal atrial fibrillation, we should start with class 1 antiarrhythmic drugs, and if failed or intolerated, we should go for catheter ablation as class 1 indication, of course. Persistent atrial fibrillation, we should start with antiarrhythmic drug, of course, as a first choice, but if failed or intolerant, we should go to catheter ablation as class 2 level of evidence A. And in the patients with long-standing persistent AF, we should go for antiarrhythmic at first, and then class 2B, a catheter ablation of atrial fibrillation. And then Dr. Damati said something about the Castle AF trial. The Castle AF trial was a very large trial, or the largest one, including more than 4,000 patients, comparing atrial fibrillation ablation and medical treatment in patients with atrial fibrillation and reduced LV ejection fraction, congestive heart failure with reduced LV ejection fraction. And it shows a clear benefit of the ablation arm in terms of death, hospitalization for worsening of heart failure, death from any cause, and hospitalization for worsening of heart failure. So the Castle AF changed somewhat the guidelines, making that the patients with heart failure or suspected tachy-induced cardiomyopathy to have atrial fibrillation ablation as first line treatment class of evidence. It's a class 1 level of evidence A if the patient is aware about the complication of ablation and intolerant, or he's not willing to start antiarrhythmic drugs. So the last question is when to refer or when to ablate. Recently, I think yesterday or the day before, in the American Heart Association meeting, we had the early atrial fibrillation trial. The atrial fibrillation trial was the largest trial to compare early atrial fibrillation ablation as first-line therapy in comparison to antiarrhythmic drugs by using cryoablation, and all of the patients were monitoring by implantable loop recorder, and this was marvelous results concerning the ablation. The primary outcomes was the freedom from any atrial tachyarrhythmia or continuous cardiac monitoring. Of course, the ablation arm was significantly better with 24.9% absolute reduction. The secondary outcomes, the freedom from symptomatic arrhythmia, it was also markedly better in the ablation arm with 15.2% absolute risk reduction. And the secondary outcomes, the arrhythmia, the freedom from arrhythmia, of course, it was better in the ablation arm versus the antiarrhythmic arm. So it concluded that it was the first study, of course, of cryoablation to start the ablation as first-line therapy in comparison to the antiarrhythmic drugs. Time to the first recurrence of AFib, time to the first symptomatic atrial fibrillation, time for the first hospitalization to a total AF burden, and days of atrial fibrillation was markedly better in the ablation arm versus the antiarrhythmic drug, and this was the early AFib trial, which was published yesterday in the American Heart Association. So these are the guidelines which will be discussed thoroughly in the next presentation, I do think. So I will not spend much time in it, but this is the recommendation for the atrial fibrillation ablation. Of course, general ones, as we all know, the decision should be taken by the physician and the patient himself, knowing the risk and benefit of atrial ablation and atrial fibrillation ablation, and could be the first-line therapy without the using of antiarrhythmic drugs. Repeated pulmonary vein isolation procedure should be considered if the patients of atrial fibrillation recurrence, provided that the patient's symptoms were improved after the initial pulmonary vein isolation. And it could be after class 1 antiarrhythmic drug failure. We can go directly for atrial fibrillation ablation, and it could be also a first-line therapy in the patients with congestive heart failure according to the CASTLE-AF trial, or the patients without major risk factors for AF recurrence, the persistent AF without major risk factor of recurrence, as an alternative to anti-arrhythmic drug class 1 or class 3, considering patient choice, benefit and risk, and this was class 2B indication. So we should individualize the therapy for each patient. Not every patient is the same, and not every patient will benefit from AFib ablation, especially if he has other comorbidities and if the patient is older and well controlled without symptoms as a rate control only. So in summary, normal sinus rhythm carries a mortality and morbidity benefit, of course. Rhythm maintenance strategy should be effective, safe, avoiding of toxicity and pro-arrhythmia from the antiarrhythmic drug. Ablation showed much more improvement than the antiarrhythmic drugs in many trials. Thank you very much.
So for the sake of time, we have time for 1 or 2 questions maximum. Professor Ramia.
Thank you, Dr. Haitham Badran, for your excellent talk. Actually, I have no question, but just a comment. The most important thing in EF ablation, not just the EF ablation itself, is the selection of the pattern of EF. The good selection for the patient, as Dr. Haitham Badran mentions this criteria. And the second point is the modulation and management of the major risk factors of EF. The most important to define what gets this atrial fibrillation in this patient. Obstructive sleep apnea, the obesity, the hypertension, the thyroid dysfunction, for first to decrease the incidence of recurrence after AF ablation. Many operators rushing to do an AF ablation and doesn't manage these risk factors. I found that later the patient has a recurrence of AF. So it is very important to define the major risk factors. I have a history with a patient has 37 years old, came to me to the clinic with reduced ejection fraction, and he was diagnosed as dilated cardiomyopathy and sent for coronary angiography. And this patient has a persistent, long persistent atrial fibrillation 4 years. And although the control of the rate by just a small beta blocker, the patient has symptoms of heart failure. But this a young patient has no hypertension, diabetes, no any major risk factors. So I think maybe an AF-induced myopathy. I tried to do a cardioversion for him pharmacologically and by DC, but I failed 3 times. DC, he received DC. I do multi-slice CT, normal, so I decided to do an AF ablation, and actually I succeeded to change this persistent AF into sinus, and I surprised that after 1 month the ejection fraction became normal completely, 65%, and the patient gained his life. So it is very important to define AF. It is an AF-induced myopathy or it is a myopathy gets an atrial fibrillation. Thank you.
Thank you.
Thank you very much for this elegant presentation. I'd like to ask you one question. Do we have national data registry for long-term ablation in patients with atrial fibrillation in Egypt?
Yes, I do think that Professor Mervat is doing some of the registries, collecting the data from the AFib ablation in our university, and I think in collaboration with the Cairo University as well, because these are the 2 centers who are doing AFib ablation in Egypt. So we have data about the AFib ablation. I do think the recurrence rate in Egypt it's similar than the abroad. It's something like 30%. So we have 70% success rate from the first procedure.
Okay.
Thank you.
Okay. Thank you very much, Professor Haitham. So for the sake of time, allow me to welcome our guest faculty today, Professor Tajana Utpara. She is the chairman of EC Guidelines on Atrial Fibrillation 2020. She is the head of Department for Intensive Care in Arrhythmology, Cardiology Clinic, Belgrade, Serbia. Assistant Professor of Internal Medicine, Cardiology at the School of Medicine, Belgrade University. We are delighted that Professor Butpara, she is joining us today. Thank you very much for accepting the invitation.
Thank you very much for inviting me. It's great honor and great pleasure to participate, and I apologize for not joining via video, but I'm joining from my hospital, so I thought that in the interest of the connection stability I should go only via audio. I hope you wouldn't mind for that. These are my declarations of interest, and my task today would be to summarize the updates in the 2020 ESC AF guidelines. What we did in 2020 ESC AF guidelines is to provide an evidence-based document streamlining the management of AF patients and care for AF patients across all levels of the healthcare system, thus facilitating a timely diagnosis and management of atrial fibrillation, whichever point of the healthcare system the patient with AF would occur in. We have summarized the essential steps in the management of patients with AF into easily remembered algorithm CC to ABC, and I will guide you through the essential steps of the CC to ABC algorithm in the next slides. The first step in the CC to ABC is C, meaning confirm atrial fibrillation via a 12-lead ECG entire recording, or at least a rhythm strip of 30 seconds or longer showing a typical AF pattern. Why is it so important? Because diagnosing atrial fibrillation should trigger a complex patient individual risk assessment and starting of therapies such as oral anticoagulant therapy with potentially serious adverse events. So at least what we should do before we start such therapies and start patient risk assessment is to confirm atrial fibrillation. Next, after diagnosing AF, conventionally we have been classifying atrial fibrillation into newly diagnosed, paroxysmal persistent, long-standing persistent, and permanent AF, and such classification has been based on a temporal pattern of the arrhythmia and the way of termination of the arrhythmia. The limitations of such approach are being increasingly recognized, and very few treatment decisions are based on such single domain classification of atrial fibrillation, which is a complex disease, as you know very well. So in the latest AF guidelines, we have proposed a paradigm shift from classifying AF looking at a single domain of the disease towards a comprehensive, thorough characterization of a patient with atrial fibrillation, addressing the four most important domains of the arrhythmia, which have treatment decision implications and likely also have overall long-term prognosis implications. These are stroke risk assessment, symptom severity assessment, severity of AF burden, and assessment of substrate severity. At the moment, we can use available tools such as, for example, CHEST-VASc score for stroke risk assessment or ERA symptom score for symptom severity assessment. But the beauty of the 4AS scheme concept and paradigm shift is that in the future, the approach or the scheme, 4S AF scheme, can easily embrace any new scoring system or assessment tools that will be developed in the future. And on top of other advantages, using the 4S AF scheme would streamline and standardize the description and referral of patients diagnosed with atrial fibrillation across all healthcare system levels. And this paradigm shift proposal has been acknowledged in the 2020 ESC guidelines by a formal recommendation that a structured characterization of AF should be considered in all AF patients, and that's to A, class of recommendation, but level of evidence C, because such approach still needs validation in daily clinical practice. After confirming AF and characterizing a patient with atrial fibrillation, next would be to proceed with the management of patients along the ABC pathways. And A stands for anticoagulation consideration in order to avoid stroke. The very first step would be to identify low-risk patients, those with a CHA2DS2-VASc score of 0 if males or 1 if females, because such patients do not really need any antithrombotic treatment for stroke prevention. Whereas in all other patients, oral anticoagulant therapy should be considered. And what is an update in these guidelines is that we clearly recommend a structured risk factor-based approach in stroke, and as you will see later, bleeding risk assessment as well, using formal clinical risk factor-based score for such assessment. Of course, risk scores are always a simplification. They help in binary decision making for decisions that are yes or no in nature, such as the decision on whether to use oral anticoagulant therapy or not. There are more complicated scores that also involve using biomarkers which are non-specifically flagging up patients with structural heart diseases. Although such more complex scores do have statistically significantly better predictive value, it does not necessarily mean that they are user-friendly in clinical practice or cost-effective. Which is also important is that individual patient risk profile is highly dynamic, so should be always periodically reassessed. Then we opted for keeping the recommendation on using CHA2DS2-VASc score and not CHA2DS2-VA as recently proposed in other international guidelines, Australian guidelines to be precise. Why keeping the female sex? Because it's not really independent stroke risk factor, but it's an important stroke risk modifier. As you can see from the nationwide cohort studies, there is a significant interaction of female sex and the presence of other stroke risk factors, and the interaction starts approximately at age of 65. So not encountering female sex in the stroke risk assessment would most likely result in underestimating stroke risk in a substantial proportion of patients with atrial fibrillation. The next to assessing stroke risk is assessment of bleeding risk, again using a formal structured risk score-based bleeding risk assessment, because such approach using the Hasbled score helps us not only to identify and address modifiable bleeding risk factors, but also to flag up patients with non-modifiable bleeding risk factors who should be scheduled for more intense regular clinical follow-up. Of course, bleeding risk assessment should be used responsibly and appropriately, because the purpose of bleeding risk assessment is not to deny oral anticoagulant therapy, but to identify and address modifiable bleeding risk factors and to follow up more closely patients with non-modifiable bleeding risk factors. And we have put it in specific recommendation that estimated bleeding risk in the absence of absolute contraindications to oral anticoagulant therapy should not in itself guide treatment decision about whether to use oral anticoagulant therapy or not. Why the Hasbled score and not some other score? Well, the overall body of evidence shows is that Hasbled score is the best validated bleeding risk assessment tool, and in comparison to the approach of identifying only modifiable bleeding risk factors as has been recommended in the previous ESC-AF guidelines. The comparison of using a structured approach with Hasbled score has been shown to be better than just looking for modifiable bleeding risk factors and has been associated with better patients' outcomes. Again, please keep in mind that both stroke and bleeding risk are dynamic and they should be periodically reassessed in every patient with atrial fibrillation. So it's not one time point and then off risk assessment in our patients. Of course, as in previous guidelines, oral anticoagulant therapy is recommended for all patients with AF who have a CHA2DS score of 2 or more in men or 3 or above in women, a class 1 recommendation level of evidence A, and should be considered in patients with a single non-sex related stroke risk factor. And in general, in all NOAC eligible AF patients, NOAC are recommended over vitamin K antagonists because they have their numerous advantages. The next component in the ABC pathway is B, which stands for better symptom control. And B for better symptom control is meant to improve quality of life and to diminish or remove the symptoms in each patient. What is the role of rhythm control strategy? Because rate control is mandatory part of the symptom management and should be instituted in all AF patients at least as initial treatment strategy. What is the role of rhythm control? Again, it is to decrease symptoms and to improve quality of life, and this is the recommendation that is supported with the highest level, highest quality of evidence from randomized clinical trials. Of course, rhythm control strategies should be considered in patients that have factors favoring successful rhythm control. The same day when the new ESC-AF guidelines have been presented, there was a presentation of the East AF-MET4 trial that compared an early intervention consistent of rhythm control versus usual care in patients with recently discovered atrial fibrillation not longer than 1 year. And the composite outcome of cardiovascular death or stroke or hospitalization for worsening heart failure or acute coronary syndrome has been significantly less frequent in patients randomized to early intervention with absolute risk reduction of 1.1%. The risk reduction from the primary outcome of the study was mostly driven by reduction in cardiovascular death and stroke, whereas there was no significant difference in the hospitalization rate, the length of hospitalization, and there was no difference in left ventricular function change, cognitive function, or quality of life. What is noteworthy is that at the end of the trial, most of the cohort were patients in sinus rhythm in both treatment arms, in early intervention arm and in the usual care arm. I'm not deliberately saying early rhythm control, but I'm repeatedly saying early intervention because there is a methodological bias in this study precluding us to make conclusions about the role of sinus rhythm achievement and maintenance in such patients. If you look at the study methods, you will see that both treatment arms were anticoagulated and risk factors and comorbidities were appropriately managed as per the current guidelines. But only in the early rhythm control treatment arm, there was an intense, regular, structured follow-up because patients were required to twice weekly record an ECG and transmit it to the study team. And they could also perform ECG recording more frequently if symptom driven, and there was a feedback from the study team if needed. So during the study, nearly 300,000 ECG transmissions have been made only in the intervention arm. This means that patients who were ready to twice weekly or even more frequently record ECG using a self-operated device and transmit it to study team were probably more adherent to all other treatments, and that's the bias of this study. We have other evidence showing that such a structured follow-up improves patient outcomes when it comes to outcomes such as cardiovascular death, all-cause death, or even composite outcome. And this evidence come from post hoc analysis of earlier randomized trials, but also from a prospective randomized trial showing that such a structured follow-up significantly improved patient outcomes. So what we can learn from the East AFNet trial is that the trial elegantly showed that an early intervention with structured follow-up significantly reduced cardiovascular adverse events among patients with AF, but the role of early rhythm control in the observed event rate difference remains unclear, and we still need more data to make firm conclusions about the role of sinus rhythm, early restoration and maintenance of sinus rhythm in this patient group. Another update comes from the indications for catheter ablation, where there is a change from 2A to class 1. As a first-line therapy, AF catheter ablation is recommended in patients with suspected tachycardia-induced cardiomyopathy, and also should be considered among patients, selected AF patients with heart failure and reduced left ventricular ejection fraction in order to improve survival and reduce heart failure hospitalization. And these recommendations have been based on the evidence from several randomized clinical trials. The third component of the ABC pathway, the C component, comes from identification and management of comorbidities and cardiovascular risk factors. And it's the last but not least important, it's equally important aspect of management of AF patients as the first two, because atrial fibrillation very rarely comes alone. It usually comes with concomitant comorbidities or is a marker of subclinical comorbidity which will become obvious early after AF has been diagnosed. And these risk factors are mutually emphasizing each other. So there is a sort of dose-responsive manner in the presence of cardiovascular risk factors or comorbidities in the risk for incident atrial fibrillation, but also the presence of such risk factors accelerates the development of abnormal atrial fibrillation substrate and increases the risk of persistence of atrial fibrillation or recurrent atrial fibrillation or progression of atrial fibrillation to a more persistent forms or permanent form. So comprehensive, aggressive and early risk factor management is important to prevent atrial fibrillation, to facilitate and improve results of rhythm control strategies, and to decrease the overall AF burden in a given patient and to improve patient outcomes. And that has been shown in several randomized clinical trials, such as, for example, the RACE-3 trial. And that is why we made a repeated recommendation about the significance of risk factor and concomitant comorbidities management in patients with atrial fibrillation. So such management should be an integral part of treatment in all AF patients, and also is very important to reduce AF burden, symptom severity, and to facilitate the success of a chosen rhythm control strategy, most commonly AF ablation. And this is the study of the holistic ABC pathway, showing that the response to the use of holistic ABC pathway is dose responsive. So the more components are met, the better is the patient outcome, and all three components, A, B, and C, are equally important. Finally, the important aspect of our guidelines is that we have emphasized that integrated patient management, which is patient-centered with active patient involvement and multidisciplinary care, is essential for successful treatment and improves patient outcomes. And as I said at the beginning, the purpose of such integrated algorithm is to facilitate and standardize the care of AF patients across all levels of healthcare systems. So it should be easy to remember to manage AF patients along the CC to ABC pathway. Thank you.
Thank you very much, Professor Potara, for this elegant presentation. We have some questions here. I will start by one question regarding the strategy of screening of atrial fibrillation patients. And 2 days ago at the AHA meeting, a vital AF study and M-STOP study involved more than 35,000 patients in primary care for screening for atrial fibrillation to identify patients earlier who are candidates for oral anticoagulation. But unfortunately, in this study, only the efficacy was proved in elderly patients above the age of 85 years. And in another study, this strategy was effective in reducing mortality and hospitalization, but not stroke. So how do you see the strategy of screening earlier atrial fibrillation in the real world practice, and how to do it properly in the daily clinical practice?
Thank you very much for that important question indeed. For the time limitation, I would not delve into specific study details, but I'll summarize the current knowledge about screening. Any screening is better than no screening. Which screening technique will depend on the local abilities, but even opportunistic screening with pulse palpation will change the outcome of patients. We know that asymptomatic patients will benefit from treatment from AF probably the same way as symptomatic patients, and that timely detection of atrial fibrillation will help prevent major adverse outcomes and complications with atrial fibrillation. But also unselected screening of the overall general population may not be rational. So what is recommended in the guidelines based on the overall body of evidence is that any type of screening, any type, any technique is recommended in elderly patients, those of 65 age or older, especially if they have concomitant risk factors for incident atrial fibrillation. And what is very important, and we made that distinction in our guidelines, is that we need to make a clear difference between screening and opportunistic case finding, because screening is present only if the whole institution or the whole country is doing the same. For example, opportunistic pulse palpation, pulse checking. Otherwise, if you at your outpatient clinic do pulse checking, but your colleague next door is not doing that, then it's not screening, it's opportunistic case finding. And equally important is if there is a national strategy for screening for AF in the elderly with associated AF risk factors, then a platform for screen suspected or screen confirmed cases for further referral and management of such patients must be in place. So the pathways of such patients need to be clearly defined. Otherwise, there is no gain from screening, because if you screen your patients and then say, yeah, listen, you have atrial fibrillation, or you maybe have atrial fibrillation, and then the system does not offer a clear pathway for that patient, you have done nothing except for increasing anxiety in such patients. So if we opt for screening, we need a clear pathway for such patients' referral, and such organized screening has been clearly associated with improved patient outcomes. What is the role of self-screening without any age restriction with increasingly available smartphone options and mobile apps? It remains to be defined, because such unlimited availability of self-rhythm screening is a major challenge to any healthcare system to provide a structured pathway for screen suspected or screen confirmed patients with AF.
Professor Dajan, thank you for your excellent explanation. I have one question. What is your strategy in management of asymptomatic patient with high atrial rate episodes detected during follow-up of their cardiac devices? Thank you.
You are referring to atrial high rate episodes, yeah. Yeah, again, to summarize in short, first of all, device detected fast atrial rhythm needs to be visually inspected and confirmed that it is an atrial tachycardia or atrial fibrillation or atrial flutter. Only visually inspected and confirmed device recorded tracings are named atrial high rate episodes, and by definition these episodes are episodes detected in asymptomatic patients with no previous history of documented atrial fibrillation. That also stands for subclinical AF. What we know so far is that atrial high rate episodes are common in the population of patients implanted with cardiac devices with atrial electrodes. So they are relatively common, and in patients with other AF risk factors, there is increased risk of progressing of atrial high rate episodes into the clinical atrial fibrillation. Patients with atrial high rate episodes, especially if such episodes are of longer duration, are at higher risk of stroke as compared to individuals without atrial high rate episodes. But the absolute event rates observed in population are lower than in patients with clinical surface ECG documented atrial fibrillation. So then again, also patients with atrial high rate episodes have higher mortality compared to those without atrial high rate episodes. So we know that from the risk-wise, from the risk point of view, these patients are at higher risks than those without atrial high rate episodes. But there are no high quality randomized clinical trials that are completed to guide our treatment. We know also that the event rate, the stroke rates and mortality rates in patients with atrial high rate episodes closely correlate with their Chest-Vasc score value. So the higher the Chest-Vasc score is, the higher is the risk of stroke and mortality. in the absence of high quality evidence, 2020 guidelines restrained from providing a formal recommendation because it would not be evidence-based. But we provided advice, common clinical wisdom that in highly selected patients, especially those with long-lasting atrial high rate episodes of 24 hours or longer and with high CHEST score, that is high risk of stroke, we can consider using oral anticoagulant therapy, of course, in communication with patient and only in those patients where a positive net clinical benefit of oral anticoagulant therapy can be anticipated. And if you look at what's happening in the real world, nearly 60% of such patients have been treated by oral anticoagulant therapy as per the decision of the responsible physician. So, I mean, I would individually assess the patient and opt for oral anticoagulant therapy should the CHEST score be high.
Yes, thank you.
And should the patient have a long.
Okay, I'm Samir Rafla. Thank you for your lecture. I have small question. The dose of amiodarone written for reversing atrial fibrillation is very high dose, 2 tablets daily for long time. You agree about this dose, and if the patient returns to sinus rhythm, how is the maintenance dose? Thank you.
Thank you for this question. Yeah, there are various algorithms for amiodarone dosing, and if you look at the table provided in the guidelines, we made a note that the dosing protocol may vary depending on the individual patient characteristics, but following the rules for loading doses of amiodarone, maintenance dosage can be adjusted as per the judgment of the responsible physician and patient characteristics. So it's not one dosing regimen absolutely necessary to follow for all. It's a subject of clinical judgment.
Okay, I think we have to close the session. Thank you very much. Thank you very much, Professor Tajana, for the elegant presentation. Thank you very much for joining us today, for your excellent contribution to our program, and looking forward to seeing you in person in Cairo soon. Thank you very much.
Thank you, and have a nice meeting.
Thank you. Hi, Professor Stephen. Professor Stephen, how are you?
I'm fine, how are you? Hello.
Good to see you.
Good
Professor
to see you.
Sobhi, how are you, Professor Sobhi? Hello.
Hello, Stephen.
Hello, how are you?
Good.
So now this is the opening of Cardiology Updates 2020. Good evening, everyone. Welcome to the second annual meeting of Cardiology Update organized by the Egyptian Society of Cardiology and endorsed by the European Society of Cardiology. Allow me first to welcome Professor Stephen Achenbach, the President of the European Society of Cardiology, Professor of Medicine, Chairman of the Department of Cardiology, University of Erlangen, Germany, founding President of the Society of Cardiovascular Computed Tomography. Thank you very much, Professor Stephen, for joining us today in this important event.
It's my pleasure.
I'd like to thank my dear friend, Professor Khalid Shukri, the President of the Egyptian Society of Cardiology, for his dedicated effort and continuous support for all our scientific activities in this difficult time. I would like to give you a short background on cardiology updates. 2 years ago, we did a joint meeting at the EC during EC Congress with Professor Parpra, the immediate past president of the European Society of Cardiology, and we raised the idea of doing an annual event under the name of the EC at River Nile. And after detailed discussion, intensive discussion for time, we reached to the title of Cardiology Updates in Egypt every year. So last year the event was a fantastic event. It was an amazing event. And we had three distinguished EC faculty, Professor Francesco Cosentino, Professor Victoria Delgado, and Professor Mitia from the Heart Failure Association. Let me to say what are the objectives of doing such an annual course is to discuss the latest EC guidelines. Every year we are attending the EC Congress and we have a new guidelines, and when we come back to Egypt we are doing sessions, continuous medical education, to discuss the recent guidelines and how to implement the new EC guidelines in the daily practice. And also in this meeting we are going to present the recent updates in cardiology and the recent trials and hot topics in cardiology, especially landmark trials which might change the practice. So the event was a great event last year. In different tracks we covered the new EC guidelines 2019. The discussion was great between the attendees, speakers, panelists, and Professor Parpra delivered a speech in the opening ceremony of this event. And this year I'd like to thank Professor Stephen for his continuous support to the Egyptian Society of Cardiology. And although we are in a difficult time due to the pandemic of COVID-19, however, he is working hard to help all national cardiac societies to get the maximum benefit from all EC scientific activities. And he is maintaining the sustained excellent bilateral collaboration between the Egyptian Society of Cardiology and the European Society of Cardiology. And of course, this event increased the visibility of the EC in the region. And this year we have attendees from not only from Egypt, but also from the Gulf region, from the Middle East. And this year also we had a guest faculty from Africa as well. So this meeting will give us the opportunity to meet with the experts of the EC, who are the chairs of the EC guidelines. And this meeting will allow us to share experience and discuss recent updates in the field of cardiovascular disease. National cardiac societies, of course, has an important role in the EC guidelines. For example, we nominate a national coordinator for the EC guidelines, and we have reviewers for the guidelines every year, as well as task force members, and we are doing an endorsement for the EC guidelines, and we are promoting the EC clinical practice guidelines on our website. So this event is very important, especially for discussion of the recent EC guidelines. So I wish you all a fruitful meeting, and I encourage all of you to actively participate in this discussion in all sessions. And Professor Stephen, he's going to deliver a welcome message from the EC and the strategic plan of the EC during the pandemic of COVID-19 and the experience of digital conferences in this time, and his support for the national cardiac societies, and the Egyptian Society of Cardiology is one of these national cardiac societies. And finally, I'd like to invite him and all EC faculty for Cardio Egypt 2021, which will be held in Cairo during the time from 15 to 18 February 2021. And until now, it is a physical meeting. So it's a great honor for us that Professor Stephen is joining us in this Congress. Thank you very much.
Thank you very much, Magdy, and thank you for letting the ESC be part of this event. Thank you for working hard to make the ESC guidelines implemented, discussed, and distributed in your country and via your country in Africa, which is a high priority of the ESC. And this is one of the many reasons that underline the close collaboration between the ESC, the European Society of Cardiology, and the Egyptian Society of Cardiology in many ways that you have outlined, not only the guidelines, but also many other committees where you have now committee members, not only in the ESC, also in the Heart Failure Association, where you are a board member. So I see this connection growing closer and closer, and I'm very happy about it. As you say, there's so much that needs to be done together. You know that the ESC has a mission. The mission statement is to reduce the burden of cardiovascular disease. And I do not have to tell you that even though we are, of course, now all preoccupied with the COVID-19 pandemic, cardiovascular disease remains the #1 cause of death in the world. And when the COVID-19 pandemic is over, we will be back to the fight against cardiovascular disease, and we must not let go of this fight. Just because we have one problem does not mean that the other problem goes away. Luckily, we constantly receive new tools to combat the burden of cardiovascular disease. And as you pointed out, the guidelines that the ESC writes and creates jointly with all of the national cardiac societies, which are all part of the process, are very important to update those practicing cardiovascular medicine with the most recent developments. And these developments never stop. We continuously have new data available. If you just take a look back at this year, there are some amazing trials that have been presented. Look at the SGLT2 inhibitor trials, Emperor Reduced, for example, which once again demonstrated that the SGLT2 inhibitor can reduce heart failure events in patients who are otherwise already very well treated for heart failure. We saw the DAPA-CKD trial, which showed a massive reduction of cardiac events and even mortality in patients with chronic kidney disease by an SGLT2 inhibitor. We saw the LODOCO-2 trial, which suggests, not absolutely proven yet, but suggests an effect of colchicine on cardiovascular outcomes in patients with stable coronary artery disease. And we have some entirely new approaches. And incidentally, in this year, 2 new drugs which are targeted at the myosin-actin interaction right in the myocardial cell have become available and present the data. There's the myosin-actin antagonist, which was mavacamten, which was probed in the Explorer HCM trial and showed a massive reduction of the gradients in patients with hypertrophic obstructive cardiomyopathy. So that's an antagonist of the myosin-actin connection in the heart muscle cell. And then we have the myosin agonists, omecamtiv. It was just released, a very large trial a few days ago at the AHA Congress, which showed an 8% reduction of cardiovascular outcomes in heart failure patients, not mortality, but combined events. But it shows that constantly we have new developments and we constantly obtain new tools and need to evaluate the relative value of these tools and which patients they might be useful for as we discuss the most important scientific findings and as we discuss and implement the guidelines. So knowledge never stops growing, and this is why, as I said initially, these corporations to evaluate science, interpret science, disseminate science, help implement the most important scientific findings into clinical practice. This is why these meetings are so important, and this is why the ESC is very happy to partner with the Egyptian Society of Cardiology. I very much look forward to the session tomorrow on non-ST elevation acute coronary syndrome that I will be part of. And once again, thank you very much for letting us be part of this, and I wish you a very successful conference, along with congratulating you on your many successful events, and once again expressing my gratitude for all the work that you put in the end, to the benefit of the patient with cardiovascular disease. Thank you very much.
Thank you very much, Professor Stephen, for this highly informative discussion for the EC activities and the collaboration between the European Society of Cardiology and the Egyptian Society of Cardiology. And we are looking for the excellent long-term sustained collaboration with the EC, and looking forward to seeing you tomorrow in your presentation about the non-ST elevation MI guidelines 2019. And we are looking to see you in Cairo next February in Cardio Egypt.
Let's hope for the best.
Yeah.
I really look forward to my next visit in Egypt.
Okay. Thank you very much for joining us today. Thank you very much, Professor Stephen.
See you all later. Have a good conference.
Bye-bye. Bye-bye. Now we have a very important session with a giant cardiologist of not only in Egypt but in the Middle East. Professor Muhammad Sobhi, the past president of the Egyptian Society of Cardiology, professor of cardiology at Alexandria University, and the governor of the ACC chapter in Egypt. Professor Sobhi is a well-known expert in intervention cardiology. Professor Adel Atribi, past president of the Egyptian Society of Cardiology, professor of cardiology at Shamsia University, and the chairman of the working group of intervention. Professor Hani Ragi, past chairman of cardiology department at National Heart Institute. We have the chairpersons, Professor Ayman Magdy is joining us.
Yes, he is online.
Yeah, Professor Ayman Magdy. Professor Ayman is a professor of cardiology at Al-Azhar University, and he is one of the experts in the field of intervention. Welcome, Professor Ayman. Welcome, Professor Sobhi. Welcome, Professor Hani Ragi. Is any other chairperson joining us? We missed them.
Professor David is online.
Professor
David. Professor David.
Professor David?
David Kabulani.
Yeah, sorry, I'm sorry. I have to introduce Professor, sorry. It's our pleasure today because nobody told me that Professor David Kabulani joined us. It's our great pleasure today that we have one of the experts in the field of intervention cardiology, Professor David Kabulani. He's an associate professor of cardiology of the University of Catania, Italy, chair of the scientific documents and the initiatives committee of the EABCI. He's a co-director of the PCR editor-in-chief for Euro-Intervention Journal, associate editor of the European Heart Journal, editorial consultant of JACC Cardiovascular Intervention, section editor of thrombosis and hemostasis, clinical research course, and associate director of TCT. Welcome, Professor Kabulani. Good to see you. Welcome.
Hello. Thank you. Thank you for having me.
We are delighted that you are joining us today in this very important session. So please, Professor Adel.
Dr. Magdy, can I say something very quickly? Magdy Abdelhamid, can you hear me?
Please proceed, Dr. Hani.
Yeah, I just wanted to say that asking speakers to come to Cardio Egypt physically is nice and very ambitious, but it's highly, highly unlikely, and I would strongly recommend that the meeting goes virtual from now, because even if they are brave enough to come, they will have to quarantine for 2 weeks when they go back, And, you know, as one of the people from the hospital who's organizing the meeting, you know, I can't see the rationale behind asking people to come physically. I don't think they'll be able to do it, and I think there'll be so many changes in the law. Thank you.
Thank you, Dr. Magdy, for inviting me to this important session. I would like to congratulate you for your continuous efforts and your persistence in having the meeting every year. Despite the fact of pandemic, I would like to welcome all the virtual chairmen with me and the speakers. And it gives me a pleasure to introduce my dear friend and colleague, Professor Mohammed Sobhi, the past president of the Egyptian Society of Cardiology. And he will be talking a very important subject, which is the PCI in STEMI with high bleeding risk. And I hope we will all benefit from this important lecture. Thank you.
Okay. Thank you, Dr. Adel, for a nice introduction. I'd like to thank Dr. Magdy Abdelhamid, my dear friend, for his continuous effort and the testing and cardiology update to Egyptian Society and European Society. When Dr. Magdy asked me to present this cases and in 15-20 minutes PCR and stimulus high bleeding risk, usually every day we have a new data about high bleeding. Thanks, David Capodano is with us. David is well known in interventional cardiology and international trials, and I'm lucky to have David with me. Let's start with defined bleeding, this high risk of bleeding. Defined bleeding, this is actually a most important part coming from BARC definitions with the 5 types from Roxana Miran, which starts 2011, that type 0 no bleeding, type 1 bleeding is not actionable and does not cause patient sick. Then type 2 overt hemorrhage actionable. Then type 3 A and B overt with hemoglobin 3 to 5, then less than 5. And then C intracranial hemorrhage, type 4 cabbage related, and type 5 probable fetal bleeding and defined. This is a definition. Then we come to a new form, which is scoring. You have a scoring of bleeding. We have a lot of scores, bleeding scores, the Action, Crusade, Acuity, Paris, Precise Depth, and BMS. But recently, academic research consortium with ARC, high risk of bleeding, they found high risk of bleeding as risk of BARC 3 or 5, and bleeding more than 4% of intracranial hemorrhage or more than 1% at 1 year. Actually, these are the most famous about depth and precise depth when we have a score more than 25, a short depth, and score less than 25 standard long depth, should include hemoglobin, white blood cells, age, creatinine clearance, prior bleeding, and scores. And this is a depth, this is after, but this is at the time of coronary stentings. Then the second issue is the assessment of the bleeding risk. How to assess? This comes different trials, and these are most famous trials have high bleeding risk PCI studies. This study and lead for DMI TBR in favor of the drug-eluting stent vidofludimus versus bare metals, a leaders-free study favor drug-coated versus bare metal, and then senior study a favor of drug-eluting stent versus bare metal. So stent compared to 1 month step in high-risk bleeding. Then comes to what do you mean by high risk of bleeding, high bleeding risk patient? It's one factor or more. These are illustrations of the factors of the patient more liable to bleeding. The elderly, more than 75, oral anticoagulants planned for after PCI, renal failure, creatinine less than 40, planned surgery less than 1 year, anemia, 11 gram less than hospitalization for bleeding, thrombocytopenia, cancer diagnosis or treated within 3 years, stroke within 1 year, severe chronic liver disease, long-term non-steroidal expected. This should be a busy slide for high risk. But now, according to the Asian Pacific Society of Cardiology, they summarize this into what's called the EBO. A, the age, B for bleeding, O for organ. Let's go for this. A, it should have a frail elderly more than 75, advanced more than 85, life expectancy less than what's called age. If you have one of these high bleeding risk, it must be accompanied by the one an additional risk factor in order to get it. Bleedings, spontaneous intracranial, recurrent GIT, hemoglobin 9, recent intracranial traumatic, recent surgery, are the approximately for surgery, this is for bleeding. And then for all which are organ dysfunction, what organs you have cause bleeding? Liver, incisional disease, bone marrow failure, and stroke. Then come to the plan treatment strategy by Tersalvi for 2020, published Journal of Clinical Medicine, that like you have acute coronary syndrome, you have local PCR preloadings. Now it's not used preloadings. Radial access most of the patient, target vessels, doing only the target vessels. Intravascular imaging is important, and then the heart team. For risk stratifications, if you have high risk of bleeding or not, risk score, clinical judgment, then come for bleeding prevention. And this depending on the blood. Then you ask yourself, if no bleeding, you continue that. If no bleeding, ask for recurrence or prevention. So concerning of what you have, monotherapy or depth shortening or depth de-escalation. These are the three items of recurrence or prevention of bleeding. Let's start by a case and see what's going on. This female is high bleeding risk, 77 years, diabetic, hypertensive, history of TIA 4 years ago, history of GIT bleeding past year, recent inferior STEMI, normal echo, creatine kinase 38. So what these patients, as you can see, this patient is elderly and with the creatine kinase less than 40, hospitalization during the past year and history of TIA. So the high bleeding risk patients. What's the angiogram? This is the left coronary angiogram is normal. As this is inferior and this is big thrombus in the proximal right coronary. Starting with the wire with the balloon 320 and there's a thrombus with a lesion. So which stent to be used? So ask yourself, Onyx, drug-coated biofreedom, BMS, or it could be science. This is done 4 months ago. So the guidelines say that in favor of biofreedom at that time, but actually, Onyx one summary slide, this is showing that there is no difference between resoluted to the biofreedoms, it's non-inferior to it, and one global study favored this also, and the one clear favored this, highly complex, high bleeding can be used, and it's a robust 1 month depth clinical program. Then comes after this, but this case was done 4 months ago, just recently, last TCT Connect, Zion short depth program, Zion's 90-20. What does this mean? You go depth for 3 months or depth 1 month. It's global USA. This is a trial design after 1 month or 3 months. It's showing that there's non-inferiority between Zion's 10-20 1 to 3 months, similar rate of clinically relevant bleedings, very low incidence stent thrombosis. So, but for this case, I choose to be a stent implantation Onyx for 26, and this is the final results. The NICOM post-dilatation was 4.5, good myocardial blush and TME2. So still risk, high bleeding risk. Actually, it's those legible reperfusion thrombolysis could be contraindicated because this patient high risk don't go for not for thrombolysis. Then cardiac cath assessment of that regimen with aspirin or the first choice is TEC or prasugrel or second choice clopidogrel. Then assessment for that 12 months and then the written information. But we actually, most of our cases, we don't have an easy case. What's the hard PCI decisions in STEMI patients? In myocardial infarction emergency, we look for acute STEMI risk and bleeding risk. It's risk more than bleeding risk in 80%. Ongoing serious bleeding in 10%, bleeding emergent risk more than STEMI risk. High bleeding risk, intracranial hemorrhage post-surgery, and then you have a STEMI. What's do you POPA only? It's what plain balloon dilatation is 10%. Then to the ask yourself, the question of antithrombotic versus the question of bleeding. If you give aspirin to the patient, prasugrel, teca, according to the guidelines, GPI, bear out, or enoxaparin Bible reading, this is a high bleeding risk. On the other hand, in intermediate risk, the antithrombotic bleeding, if you have aspirin, could be 600, cangrel, and enoxaparin Bible reading. But the lower risk with aspirin, 300 could be clopidogrel, enoxaparin Bible reading. And then the guideline, radial access. Most of these cases should do radial access in class 1A. And these patients, if you have sometimes you have oral anticoagulation, assessment of the risk is important, and look for the high ischemic risk. If you are going to give oral anticoagulant, look for this table for the short life expectancy, advanced age, evidence of bleeding. Then we come to the important part, decision of depth duration. What the guidelines say, this patient acute coronary syndrome, drug-eluting stent with high bleeding risk, yes. You have two options, aspirin clopidogrel, aspirin tecarol, or 6 months at all, and then 6 months depth class 2A, B. What the difference between the European Society, American College for Acute Coronary Syndrome, in 12 months reduced to 6 months, for a European Society Cardiology, high bleeding risk 6 months. Sometimes you can minimize the lab duration, up to 3 months for acute coronary syndrome. So which antiplatelet stop? They have a question, very important question. Which antiplatelet? We have stopped P2I12 in these trials. In this trial, Leaders 3, Senior Trial, Onyx 1, and finally be on enzymes 2890 or 3090. When they stop aspirin, this is very evident in Twilight, Smart Choice, stop DAP2, and we can conclude this is be stable. We have only 4 trials for aspirin removal with a total number of cases 29,000 patients. We have 17 trials for P2I12 removal with a total 34,000. So what we do? What recently? In TCT Connect, the TICO trial randomized evaluation of TECA monotherapy after 3 months with ACS treated with new generation sirolimus eating stents, and this is the TECA role for 3 months, and then monotherapy after that. We stop aspirin. What were the results? The primary endpoint in TICO is in favor of monotherapy for 3 months, even for the pre-specified landmark analysis, and also for less major bleedings and less major adverse cardiovascular cerebral event. So they conclude that in patients with ECS, STEMI or non-STEMI, undergoing PCI with ultra-thin sirolimus stimulating stents, actually biodegradable thermal sirolimus stimulating stents, at 1 year, TECA monotherapy after 3 months of TECA-based DAP, showing significant reduction of non-adverse cardio events compared to 12 months of TECA with less of bleedings. So the guideline remove P2I12 and not aspirin, yes, after PCR, not aspirin. But risk of coronary disease patient needs lifelong aspirin, yes. A lot of trials, compact, Themis, Christmas, DAP, Triology, we have a lot of trials. So we need to have antiplatelets a long time. But don't remove the last antiplatelet during PCI, and this evidence in twice 2, they showing decimal non-fatal infarctions, and also for less major bleeding. Mr. Chairman, my colleagues, of my final thoughts. High risk of bleeding needs proper assessment. Choose the best stent with short duration. We have so evidence of a lot of trials. We have Biofreedom, Onyx, recent designs, and sometimes bare metal stents and big stents. But you should assess the risk of bleeding. Finally, strict guideline for depth of short duration. We have a lot of guidelines favoring for European guidelines, American guidelines, short duration, and thank you very much.
Well, thank you very much, Professor Mohammed Safhi. I noticed a question from Professor Hani Ragi that why not, when you choose your stent, why not Cobra? What is your response to that?
I know this. These tried this, but first is the Biofreedom, and then coming the Onyx trial, because this is a drug-eluting stent coming for this, and we have a lot of trials for them, and then the same. But the Cobra stent is not so evident to have its. I know this the claiming on this, but not for 1 month or 3 months for the Cobra.
Okay, Professor Hani, do you have anything to add?
Thank you. I actually especially mentioned the Cobra because I saw David is here, David Capodanno, and you know the Cobra is the second generation of the Catania, which is named after the beautiful city in Italy where he practices and he works. It's an improvement on bare metal stents, and it's certainly an improvement on delivery of the Catania, which was a stiff stent. I have placed in unique situations with truly high bleeding risk. I mean, when I say high bleeding risk, I'm talking about a patient who developed a STEMI because he was vomiting blood because of a perforated ulcer. So this is high bleeding. And this is a primary angioplasty, and the patient can't go in and do, and I actually, in a case like this, it's anecdotal, but a lot of our experience is anecdotal. I actually did what Ayman Abdelhamid, my colleague who is a few months older than I am, but has been my mentor for many things. I just performed a PTCA. I did a primary PTCA. I did not even put a stent because I knew I couldn't give this patient anything. And
But Hani nowadays,
as soon as we control it,
nowadays you have a
so I'm just saying that there are, I mean, when you talk about high bleeding risk, the manufacturers try to include a lot of patients who are old and have bad kidneys, etc. But some patients are seriously high bleeding risk, and that is, where we have to have unusual options.
Well, I think there is another question from Professor Ayman Abdelhamid. Professor Ayman, can you just...
can you hear me?
Yes, we can hear you well.
I'm unfortunately, I'm hearing everything very interrupted, but it's a very, very complex subject, extremely complex, and we still have a lot of evolving data. I think that high bleeding risk patient, I think it's very important to differentiate between a high bleeding risk patient who is an elective PCI compared to an acute myocardial infarction PCI. This because the acute MI patient is obviously also a very high ischemic risk patient, and the decisions would have to be quite different from an elective PCI in a high bleeding risk patient. So this is a complex issue. The data is still coming out. When do we stop two antiplatelet therapies? I think it will always end up being individualized. For example, if I have a patient like the one Hani mentioned just now, where he had the patient with a bleeding ulcer, and he developed an infarction because of the excessive bleeding. For that patient, I would probably just give aspirin for a few days and then continue with, I would optimize. I think it would be very important to optimize the procedure with imaging and make sure the stent is optimally deployed, allowing me to minimize the duration of dual antiplatelet therapy, even if it's going to be aspirin for 1 or 2 or 3 days, and continue with just, say, clopidogrel. But I think in the high bleeding risk patients where we want to minimize the duration of our drugs, I think it's very important to have a near perfect procedure, if whenever possible, with imaging.
Thank you, Professor Ayman.
Professor Sobhi, I have a question regarding assessment of bleeding risk. Do you prefer a specific bleeding risk score or just clinical judgment only is enough?
Yeah, these very important questions. As you remember in my slides in the beginning, there were a lot of scores. Sometimes it's difficult. But then comes to the following the Annex 1 and clear this table of maybe 15 items. And then finally, I found it's easier according to the Asian Pacific, this ABO very important. It's clinical, that the age is important, then you can take one for the bleeding and one from the organ, maybe one of them adding to the age. I think the clinical is important rather than to make it score. It's not like grace score for the ischemia going to the cath lab or not. So bleeding is individualized, but you have a clinical level. Look to the table and then see it. The problem, as Hani said, Ayman said, that it's different. I asked you to have the presentation acute kidney syndrome, but you told me it should be STEMI. So I'm concentrating on the STEMI case, but actually it differs between the duration between STEMI, elective, and non-STEMI. In STEMI patients, it's life-saving and more bleeding, so it should be concentrated cautiously. And there's no doubt that use the stents with less short duration. For non-STEMI, you can assess yourself according to the number of stents used, because it is sometimes high ischemic and high versus bleeding. So you can judge. If you are looking to get this patient adapt for a longer time, you can maybe choose surgery rather than doing stents. For the same for the stable patient. And because the duration, it takes longer than the STEMI patient. So depends. Number one, the answer to your question, no, I don't use a score, but I use individualized, but I use the ABO of the Asian and one table of the Onyx curve. Number two, the answer to Hani, use a bare metal stent? No, I use a drug-eluting stent now, because already drug-eluting stent have a short duration, maybe 1 month, 3 months, and you can discard one, can start aspirin and go only for P2 part.
Okay, thank you very much, Professor Sobhi, for this wonderful presentation as usual. Thank you very much.
Okay, can I just add something?
Okay. Okay, Dr. Hani, go ahead.
Is Dr. Badawy with us?
Yes, I am.
Yes, this is Ayman. You recall at the last TCT we were walking and we discussed this issue specifically. And I would like to hear your opinion because in our discussion we mentioned back to the future. Remember?
Yes.
Minimizing the duration back to where we were in the early days of drug-eluting stents. Can you give us your insights, please?
No, these were good days because it was before the pandemic when the world was a different and better place, definitely. So I recall those days with pleasure, and you, of course. So yes, no, I don't want to steal too much time, but basically, yes, the area of antithrombotic therapy on this topic is really evolving. In the ESC guidelines that you will discuss in the Congress tomorrow, basically there is a new section on antithrombotic therapy for ACS, and actually there are many strategies that are proposed for patients with and without high bleeding risk, such as the aspirin-free strategy mentioned by Professor Sobhi, but also the de-escalation, as well as the shortening of the APT up to 3 months or even 1 month. We have listened to recent data from the American Heart Association. So as you say, it's back to the future. It seems that it's never done with this topic, and there are many new hypotheses and strategies, especially for patients at high bleeding risk, that now needs to be compared. But yes, it's good to see that there is still interest and research in this area.
Okay, thank you very much, Dr. David, for this comment. Now we have to move for the next speaker. I had the pleasure to introduce Professor Adel Atrapi. Professor Adel, one of the pioneers in the field of intervention cardiology, and today he is going to discuss a very important and challenging topic, which is bifurcation lesions, which is the best technique. Professor Adel.
Yes, thank you, Dr. Magdy, for the nice introduction, and I would like to welcome the speakers. Actually, my task is a little bit hard to do it in 20 minutes, but I will try to move fast. And بتجيب البتاع منين؟ هو السلايدز كلها كده ولا السلايدز هتبقى صغيرة كده كلها؟ Okay. Okay. I actually, being the ESC update, I quoted most of this lecture from the step-by-step manual for planning and performing bifurcation by Dejan Milosevic and Goran, the famous Goran. So I will try to summarize what they said, and I will put some of my input into the lecture. Actually, they stated that you should study the anatomy, the resources, and the evidence. I will not talk about the resources. We have difficulties here in Egypt, but I think we are overcoming it. But I will talk mainly on the anatomy and the evidence behind it. And they said that there are 3 A's before you say bifurcation PCI. You have to assess the lesion, anticipate, and then align with bifurcation plan aligned with the anatomy. And there are very important 3 diameters that you can take care of. I will tell you again. What is a complex bifurcation is the bifurcation that need really intervention in the side branch, whether by kissing balloon, by other stenting or whatever. And by the true definition, there is more than 50% lesion in both the main and side branch. The burden of severe atheroma extends about more than 5 millimeters of the side branch ostium, and the side branch is supplying a big area of the myocardium, so its size should be 2 millimeters or more. And this is the famous Medina classification. I will not waste your time in it, but these are the 3 diameters that you should memorize. G1 is never equal to G2. G1 is usually D1 is the diameter of the main vessel, the distal vessel, distal main, and the branch. The finite law, or the finite law, is the law we are using now routinely, which is 2/3 of the sum of D2 and D3. Sometimes I use this to know the diameter of left main, for example. If I have a clear diameter of the proximal LAG and a clear diameter of the circumflex, I can, in a way, hypothesize the diameter of the left main or the main vessel of bifurcation. So you can do it the reverse way, by multiplying 3 by 2, the sum. So the rule is G1 is never G2. G1 is always bigger than G2. But if you're going to put a stent, as I will show you, then you should size the stent as G2 and then enlarge it by a pot. The plaque distribution, contrary to what we used to believe, is never on the carina. It's always opposite on the carina, because on the carina there is a shear stress all the time, so you don't have actual plaque at the carina, but opposite the carina, as you can see from this slide, is the usual site of the plaque. The angle of the side branch is important. If it's an acute angle, then you can easily access it, but you can difficultly cover the ostium, and so that's why in such lesions, maybe a decubic crush or culotte, it depends. But if the angle is wide, then it will be very difficult to access, but at the same time, you can easily cover the ostium. Wiring and rewiring, we have dilemmas. Should a side branch should be routinely wired or not? Can a polymer-coated guide wires, I'm frequently asked this question, can you gel a polymer-coated guide wires? And what is the correct technique for side branch rewiring? So, upfront side branch wiring increases the chance of side branch reopening after main vessel stenting, including acute side branch salvage. You know, the gel technique, if you can pass the balloon, very small balloon under the struts, if you cannot really recannulate the side branch. And polymer coated wires, although they are okay to be gelled, but you can ungel. When removing the wire, you might part of the materials of the wire will embolize distally, and it's resilient to damage compared to the non-polymer coated or the non-polymer coated wires. So if you have an advice, then don't use polymer coated for side branch gelling. Distal strut rewiring is better than proximal strut for better side ostium scaffolding. So always put 2 wires. The only way you not put a wire in the side branch is when you have a normal ostium of the side branch and an acute angle, so easy access to the side branch. But never put 1 wire if you have difficult access to the side branch or a lesion in the side branch. The second dilemma is pre-dilatation. Should side branch pre-dilatation be routinely performed? Well, immediate post-stenting tenuflow is better if side branch is pre-dilated. There are some speculations that, well, you will induce some barotrauma, you might cause a dissection in the side branch, but anyway, you have to carefully assess the side branch if pre-dilatation is performed, and don't use oversizing of the balloons or high pressure. But you can always have a bailout tap or reverse it provisional. Should we routinely? Because I think if we do side branch dilatation, then there is a chance for better alignment and better access to the wire later on. And this is the main branch dilatation. If flow is impaired, you assess the difficult, and in presence of severe calcified lesions, you should do dilatation. If there is no involvement, as I told you, only a single wire, you don't need 2 wires. And when performing side branch pre-dilatation, it's not recommended to use the same balloon as we sometimes do because of financial issues. We use the same balloon we use to dilate the main branch, but usually use a fresh balloon with an undersized balloon. The main branch stenting, also dilemma, is how to choose the diameter and the length of the main branch stent. For the length, you should have enough distance to put a non-compliant balloon to do a pot. And for the diameter, choose the diameter of the distal vessel, then pot the proximal part. Diameter should be sized, as I told you, at the distal main branch. And you should also study the expansion capacities of different stents. And we know that the synergy stent, the Ultimaster, and some more stents can expand to higher values. But the Expedition, for example, but the Resolute Onyx only 0.75. And most of the stents are over-dilated to 0.75, not more than that. So when you choose a stent, please, and you know you have a bigger main branch, then choose a stent that you can really post-dilate with a bigger balloons. The dilemma of main branch stent optimization, how to correctly perform pot. Should kissing balloon inflation routinely be performed in provisional single? And when can pot side branch dilatation pot sequence can be used? And these are important dilemmas that us as interventional cardiologists must face and must know what to do. Pot is mainly used, of course, to correct the proximal part because you put the stent at the size of the distal part. Routine kissing in provisional stenting did not cause any improvement. It might cause some morphologic satisfaction to the operator, but it will not prove outcome. Sometimes we do a pot side pot. That means we dilate first the main branch, side dilation of the side branch, and then do the pot again, and always use non-compliant balloons to do the pot. This is an example of the sizing. Of course, you choose the distal vessel. The pot, as you can see, it has to be done with the size of the proximal vessel, and then do the side, for example, pot. And this is an example of مش عارف دي هتمشي ازاي بقى of optimal optimization. You can see it's very important to look here that the marker of the balloon should be at the distal part of the bifurcation, not at the proximal part of bifurcation. If you do distal part, proximal part, you will never do a proper side branch access. So be sure that the marker of the balloon is at the distal part of bifurcation, or even half millimeter after it. This will give you the perfect pot. You see, in this illustration, this is the perfect pot. The balloon, or the marker of the balloon, should be at the distal end of the bifurcation, not at the proximal end, as we used to do in the early stages of pot that we used to learn. How to perform an optimal final kissing? Well, I will tell you the recommendations. It's optional for provisional stenting. It's obligatory for complex techniques. Side branch, this is very important. Side branch should be inflated first before the main branch, and then you deflate both at the same time so that you will not distort the stent in the side branch. Short balloons, use always short balloons, and always use non-compliant balloons. This is very important for kissing balloon techniques. And always do long inflations to allow proper alignment of the stent and proper deployment of the stent. And this is the main branch stent optimization. You see how do you do the pot, kissing balloon, pot side pot, and it's not recommended to post-dilate the main branch stent distally to the carina, because if you do that, you might lose the side branch. And routine kissing balloon inflation in provisional stenting is not the recommended choice. So, one or two stent strategy? Well, this is the algorithm of bifurcation. And you can see here a lot of things, but if the side branch have a lesion of more than 70%, then a two-stent strategy from the start, you can do it, and the lesion is more than 10 millimeter in the side branch. If it's less than 10 millimeter and less than 70% side branch lesion, then you have to decide. If there is an easy access, you can easily access by the wire. You don't need to wire it, and even provisional. If the access is not easy, then you must think of two-stent strategy, and in this case you do the side branch first, and I think the preferable is a DK crush. When it's two-stent technique, it's a DK crush technique. So provisional stenting, the technique, I will go short. I hope I still have some time. The provisional stenting, you do wire both branches, single stent crossover, and then a pot. This is the first option. The second option is do pot, kissing balloon, and then pot again. And the third option is pot, side pot. So in provisional stenting, we have three options. The traditional stent, then pot, or pot, kiss pot, or pot, side pot. And this is an example of pot. As I told you, the marker of the balloon should be at the distal part of the bifurcation, not at the proximal part, so that you will allow a good opening of the side branch. Pot, side pot, it's simple. You just do the pot, rewire, and then balloon only in the side branch, and then pot again. This is called pot, side pot. Finally, the two stent strategy. I will go through rapidly into the different techniques. The Kellogg techniques, I will choose it when the main and side branch are equal in diameter. That technique, I usually use it for bailout for provisional stenting. And DK crush was voted as the best technique of two stent bifurcation, especially in difficult angle side branch. Simultaneous kissing stent technique, sometimes you use it in emergency situations. And now we have a new technique that needs further studies, which is called the nano crush technique. And the nano crush is a new modality that I think needs more studies. If you allow me, I have 1 minute of a video showing you the step-by-step approach to DK crush. So you put two wires in the side branch and main branch, stent the side branch first, and then deploy the stent in the side branch, remove everything, the wire and the balloon, and then crush it by the balloon in the main branch, then recross the wires through the struts of the stent, and do the first kiss. This is the first kiss. Then you remove again everything from the side branch and put the main branch stent. You see, you have to move because you'll jail under two layers of stents. This is the main branch stent. And then rewire again and do the second kiss. These are the usual steps for DK crush, and you finally end by pot. And remember, when you do a pot, always have enough length of the stent in the main branch so that it will allow you. And that's what we call resources. Before putting a stent, you should know the diameter of balloons you're using and the diameter of non-compliant balloons available in your cath lab before choosing the length of the stent in the main branch. So my take-home message, Mr. Chairman, is that in bifurcation lesions, proper planning of procedural with respect to anatomy is a must. Side branch wiring is almost always the most recommended strategy. The choice of one technique over the other depends on the anatomy, the size, and the angle of the side branch. Provisional stenting should be the default strategy. The choice of two stent technique depends on the angle of the side branch and the experience of the operator. And my advice to young operators is to master one or two techniques at least, not all techniques and do nothing, just master two techniques and do it in the proper way. And I believe, myself personally, I believe the DK crush technique is the preferred technique for complex bifurcation lesions. Thank you.
Thank you very much, Professor Adel, for this excellent presentation. I have a question regarding left main bifurcation in provisional stenting, crossover left main LED. Is it necessary to do kissing after left main bifurcation, or it is the same for any bifurcation? There is no need for kissing after provisional stenting.
If provisional, you don't need kissing, or kissing will not help you much unless there is some compromise in the ostium of the circumflex, and then do the kissing. I hope it will be in the next lecture given thoroughly. But benchmark studies, strangely enough, showed that kissing compromises the flow in the vessels. It's a benchmark. It's not real clinical. But kissing seems not a very good idea in strategy without two stents, and not only one stent.
Any question from the floor, from my co-chair?
Professor Capodano, Professor Sobhi, Professor Abdelhamid, Professor Ragi, any question?
Unmute, Ayman, unmute, please.
Now, I enjoyed the presentation very much.
Okay.
And that's all I have to say.
Thanks to Milosevic and Goran, actually. I just put a small input from my side.
Dr. Hani?
Yes.
Any question?
I just want to make one point clear. Every time people like Antonio Colombo come to Cairo and they give courses on bifurcations, in the week which follows the trip, we have a lot of complications. Because a lot of young people see the videos of wires going into side branches and think this is something which is easy. And, they put a side branch stent and they crush it and then they can't cross. Okay? And they can't cross for many reasons, and one of the main reasons is that the practice in Egypt, in many small private cath labs, is very dependent, very economically dependent. They can't use more than one wire or two wires per procedure. Professor Abdelhamid just mentioned that they can't open a new balloon sometimes, and it's very, very important to know that the videos that you see of bifurcations being done are not that easy. It's not like the cartoon. I mean, in many instances, your wire will give you a lot of trouble to cross, and you know what? After you cross, people will tell you, no, you crossed in the wrong strut. You have to go to a more proximal strut after you spend 40 minutes to cross. So bifurcation PCI is important to practice and to be proctored in and to have somebody who, and also you should, if you're going to start working bifurcations, you should not be thinking about how many wires or how many balloons you're going to use. That's my point.
Well, bifurcation is a great specialty, and I think there is now the European Bifurcation Club, and just announced the American Bifurcation Club, just announced a month ago or 3 weeks ago. It's a different subject, and it needs more and more research, mostly benchmark research, because these benchmark researches can give you a lot of answers of what you think is routinely done should not be done. So I hope in the future we'll have more and more data on new technologies and new ways of assessment. But I think for the time being, if you have to master a technique and you have to do it the proper way. Don't make compromises, because if you make compromises, you will have a long-term bad results. So I think the best way is to do it the proper way, in the proper steps, or don't do it at all.
Well, if there is no more question, I can thank a lot Professor Trebi for his excellent talk, and we go for the next presentation.
It gives me a great pleasure and honor to be presenting the host of this meeting and the president of the working group of heart failure, and the past president of the Egyptian Society of Cardiology, and has been recently elected also in the committee in the European Society of Cardiology for the guidelines. I'm very glad to be chairing this session, and it's an honor for me to present Professor Magdy Abdelhamid. Professor Magdy.
Thank you very much, Professor Adel, for this kind introduction, and really I enjoyed the two previous presentations by Professor Sobhi and Professor Adel, with the great interactive discussion led by Professor David, Professor Hani Ragi, and Professor Ayman Abdelhamid. And my assignment today is a very challenging topic, which is renal denervation therapy for hypertension. What do we stand in 2020? Is there any role for renal denervation or not? don't have any conflict of interest regarding this presentation. We know that hypertension is the leading cause of mortality. We can see here that if you have a blood pressure systolic more than 140, this carry the risk for mortality due to ischemic heart disease, ischemic stroke, hemorrhagic stroke, other cardiovascular disease, and chronic kidney disease. Unfortunately, uncontrolled hypertension in the daily practice is commonly due to non-adherence to therapy. So a non-adherence leads to uncontrolled blood pressure, and many patients identified with resistant hypertension phenomena may actually be non-adherent to prescribed medication. And we can see here in this slide, which involved 300 patients prescribed different antihypertensive medications, we can see that the majority of patients with apparent treatment-resistant hypertension are non-adherent to prescribed treatment. So if you look for CCP prescription for 223 patients, only patients who have regularly taken the drug 130, and this was estimated based on urine sample looking for the metabolite or the drug. Whether using the RAS blockers, diuretics, beta blockers, actually the adherence to take the drug regularly is much lower compared with the prescribed medications. So hypertension is associated with increased risk for morbidity and mortality, and despite the availability of safe and effective antihypertensive medications, even single pill, double pill, or triple pill combinations, in many patients blood pressure control, the guideline recommended target cannot be achieved. So renal sympathetic denervation is the most extensively investigated device-based therapy for hypertension, and the randomized sham-controlled trials have provided proof of principal data for its blood pressure lowering efficacy. So what is the rationale for using renal denervation in patients with hypertension? We know that overactivity of the sympathetic nervous system contributes to the development and progression of hypertension and may be associated with increased cardiovascular risk. The kidneys, and in particular the efferent and the afferent sympathetic nerves, have a crucial role in blood pressure regulation. Stimulation of the efferent sympathetic nerve activity increases the renin release by beta-1 stimulation at the juxtaglomerular apparatus cells. So this will increase renal tubular sodium reabsorption and decrease renal blood flow. And this slide shows the relationship between the CNS and the kidney, afferent and efferent nerves, and this have a regulatory effect for the vascular tone as well as myocardial function. So increased sympathetic activity in hypertension could be responsible for increased vascular resistance, increased vascular remodeling, smooth muscle hypertrophy, and at the kidney level, increased renin release, increased RAS activation, and increased sodium retention, and decreased renal blood flow, and interruption of this central and kidney relationship by renal denervation could lead to blocking the renal sympathetic activity and decreasing blood pressure. So we have catheter-based renal denervation started 2009 by Simplicity Hypertension 1 trial. The publication of the first in-human trial of radiofrequency-based denervation. This was followed by Simplicity Hypertension 2 and Simplicity Hypertension 3 trial. Simplicity Hypertension 2 trial was positive regarding the blood pressure lowering effect of renal denervation. In Simplicity Hypertension 3 trial, no significant difference in blood pressure reduction between radiofrequency-based renal denervation and sham procedure. So the trial was considered as a neutral trial. So in the last 3 or 4 years, we have an important new trials, which is spiral hypertension off medication trial, which is the first proof of concept for blood pressure lowering efficacy of radiofrequency-based renal denervation, and then spiral hypertension on medication trials, radiofrequency-based renal denervation reduced blood pressure in patients receiving antihypertensive therapy, and we have a global Simplicity registry which proved the safety and sustained blood pressure reduction at 3 years follow-up. And this slide summarizes the sham control trials comparing radiofrequency ablation versus sham procedure. And if we look for Simplicity Hypertension 3 trial 2014, the use of mono-electrode radiofrequency ablation in 364 patients proved a reduction in blood pressure with renal denervation compared with sham procedure. However, this was not statistically significant. If we look for spiral hypertension of medications, the difference in methodology is the use of multi-electrode helical radiofrequency ablation, a new catheter, and in this trial, which involved initially 38 patients, the change in 24-hour ambulatory systolic blood pressure at 3 months was statistically significant, 5.5, the difference between renal denervation and sham procedure, and this was statistically significant. And the same for spiral hypertension on medication, a statistically significant difference using radiofrequency ablation compared with sham procedures. And this interesting slide summarizes all trials compared renal denervation with sham or not sham control. If we look for the sham control trials, we can see Simplicity Hypertension 3 trial, and we can see here the baseline systolic blood pressure in the range of 180, the change in the ambulatory blood pressure at 6 months, which was 6.7, and the mean change in systolic blood pressure at 6 months, which was 14.1. And this was not statistically significant in a study included 500 patients. And similarly, in other studies, but in other trials like Simplicity Hypertension, off and on medications, this was a sham control trial, and it proved the efficacy of renal denervation in lowering blood pressure. Again, this is the Simplicity Hypertension 3 trial, and although renal denervation was associated with significant reduction in blood pressure, the same for the sham procedure. However, the difference between both procedures was only 2.39, which was not statistically significant. This is for office systolic blood pressure as well as 24-hour ambulatory blood pressure. So recently, Medtronic introduced a very interesting new multi-electrode catheter with quadrantic vessel contact for simultaneous ablation in up to 4 electrodes. We can see here the 4 electrodes, and this allowed the circumferential ablation for the renal artery, and the 60 seconds simultaneous energy delivery, and the vessel diameter should be 3 to 8 millimeter. Flexible catheter allow branch treatment because this is important to be ablated, and this is compatible with fixed French guiding catheter. And in Medtronic renal denervation clinical program started by spiral hypertension of medication trial, which was published 2017, spiral hypertension on medication, and the most important is the global Simplicity registry, which involved up to 3,000 patients. If we look for the data from spiral hypertension of medication primary analysis up to 3 months follow-up, we can see here the blood pressure change at 3 months. Look for the 24-hour systolic blood pressure, renal denervation compared with sham procedure, a statistically significant difference, 4 millimeter, which was significant, and 24-hour diastolic blood pressure also was associated with 3.1 millimeter mercury difference between both, and this was statistically significant. The same for the office systolic blood pressure, renal denervation was associated with better outcome compared with the sham procedure. And you have to remember that even 10 millimeter mercury reduction in the office systolic blood pressure is translated into a meaningful reduction in the risk. Major cardiovascular disease risk reduction by 20%, coronary artery disease risk 17%, stroke by 27%, heart failure 28% reduction, and mortality 13% reduction. So this is very interesting slide because it shows that renal denervation demonstrated an always-on effect on 24-hour blood pressure lowering. Look for the nighttime, early morning period, which is the high-risk time, high-risk zone associated with increased risk of stroke and cardiovascular events. Look for the comparing the renal denervation with the sham control. We can see that with renal denervation, significantly lowering blood pressure at this critical time
with a statistically significant p-value compared with sham control. So 24-hour systolic ambulatory blood pressure lowering at 3 months, and specifically lowering blood pressure at the early morning and night time, which is associated with the reduction in stroke and cardiovascular risk. For any innovative procedure, safety issue is very important, and safety results were documented in the spiral hypertension of medication. If we look for this slide, look for death, new onset end-stage renal disease, significant embolic event resulting in end organ damage, renal artery perforation or dissection require intervention. No patients developed this complication, vascular complications, hospitalization for hypertensive crisis, new stroke, major bleeding, and rise of serum creatinine or new onset myocardial infarction. So safety issue was proved with the renal denervation. So they summarized the data of spiral hypertension of medication that among patients with uncontrolled hypertension, renal artery denervation compared with sham procedure was associated with significant reduction in blood pressure, and no major device or procedure related safety events, and the data up to 3 months significant reduction in blood pressure. In patients who were randomized in simplicity hypertension on medication trials, the same benefit also was proved regarding blood pressure change from the baseline to 3 months. Look for the 24-hour systolic, 24-hour diastolic blood pressure, up to 7.4 millimeter mercury reduction in blood pressure systolic, and 4.1 reduction in diastolic blood pressure. And the same benefit in office systolic blood pressure, 9.4 versus 5.2 for diastolic blood pressure. So both office systolic and diastolic blood pressure reduction was significant. And for the simplicity registry study, we can see that follow-up up to 3 years, 6 months, 1 year, 2 years, 3 years, the office as well as 24-hour ambulatory blood pressure was associated with significant and continuing reduction. And up to 55% of resistant hypertensive patients achieved a more controlled level of blood pressure at 3 years without an increase in the medications burden. Look for the number of medications, but you have to look for the baseline blood pressure. 44% of patients at the baseline have a blood pressure which is 160 to 180, but in follow-up up to 3 years, only 20% have this level of blood pressure. And interestingly, at the baseline, no patients have a blood pressure less than 130 millimeter mercury. At follow-up 3 years, 17% have a blood pressure less than 130 systolic, and 19% have a systolic blood pressure between 130 to 140. So in total, 55% have a blood pressure controlled compared with the baseline level of blood pressure. What about the efficacy on the renal function? This is very important. And the data of renal denervation proved that 3 years follow-up in global simplicity registry that the effect on renal function was beneficial in preserving the renal function. Look for the estimated GFR at the baseline, which was 46.7. And at follow-up, the GFR is high for patients subjected to renal denervation, so the procedure was safe for the renal parenchyma. Look for the spiral hypertension clinical trial program, spiral hypertension of medications and on medications, randomized trials, sham controlled, proved that these procedures was associated with statistically and clinically significant blood pressure reductions, no major safety events, always on effect blood pressure reduction throughout the day and night. Global simplicity registry, long-term, up to 3 years, which proved the efficacy, durability, safety in a broad real-world population, significant blood pressure lowering effect at high cardiovascular risk patients, including elderly, diabetic patients, isolated systolic hypertension patients. Sustained drop in blood pressure independent of medications, and renal function is maintained. And this slide also summarized the global simplicity registry data regarding the benefit of reduction up to 3 years, the efficacy and safety of this procedure, and the question, is there any risk for re-innervation of the renal nerves, which are going to be ablated by radiofrequency ablation. This is a very interesting study, which is radiofrequency renal denervation performed in 164 healthy swine, serial histological tissue samples to see the renal nerves. So if we look for the normal nerve function at the baseline, lack of fibrosis, blood supply intact, but within 7 days, we can see the increased inflammatory infiltrate, fibrosis, loss of blood supply, and after 60 days, fibrosis and hypercellularity are well seen. But even up to 180 days, the fibrosis and the hypercellularity persisted. However, which is most important, that no restoration of organized nerve bundles, which means that functional nerve regrowth is highly unlikely to develop up to 180 days after renal denervation. And this interesting slide showed that 63% of kidneys had renal nerves that join distal to the main renal artery bifurcation, which should be ablated, and 30% of cadavers had accessory arteries and also should be ablated. Look for the real-world data for the long term regarding cardiovascular death, myocardial infarction, stroke rate, end-stage renal disease, creatinine elevation, new renal artery stenosis. And renal artery stenosis development was documented meta-analysis up to 0.2%, and the majority within the first year. Hospitalization for new onset heart failure, 4.1%, atrial fibrillation, 3.5%. This is in resistant hypertensive patients involved 1,229 patients. And this is the role of renal denervation in many consensus statements by different societies. So this is the Society for Hypertension, Italian Society of Hypertension. And in this slide, the flow chart, which is important for cardiologists, for GPs, for hypertension specialists, that any patients who have difficult to control blood pressure, office and 24-hour blood pressure and heart rate evaluation is important. Global cardiovascular risk assessment, screening for secondary hypertension causes, drug adherence and tolerability assessment, and shared decision making between the physician and the patients is important. Optimization of blood pressure lowering therapy is important. If the blood pressure is controlled, continue treatment. If the blood pressure is not controlled, then you have to consider for renal denervation, multidisciplinary staff evaluation for renal denervation, and shared decision making with discussion of the benefits and risk of the procedure is important. So the European Society of Hypertension statement and position paper for the renal denervation, and they demonstrated in this position paper that renal denervation had the evidence to lowering blood pressure. Sham subtracted reduction in ambulatory blood pressure provides clear message that renal denervation is effective in lowering blood pressure in resistant hypertensive patients with or without using antihypertensive medication. Also, renal denervation provides clinically meaningful blood pressure reduction, and the evidence shows that the procedure is safe. No major adverse events in the trials which have been presented. And also it should be individualized, not for every patient with hypertension. Should be considered only any specific indications, and so it should be considered in blood pressure elevated above 150 millimeter mercury despite prescription of guideline-based approaches taking account individual patient condition. Rule out white coat and secondary hypertension, which are important causes for resistant hypertension, and the intensive discussion with the patients on risk and benefits of the renal denervation, taking into consideration the patient's preference, which is important issue. So it is not for routine general use in patients with hypertension, not for routine or general use in patients with hypertension. And this is the final slide. Who is the renal denervation patients? Patient with or without antihypertensive drugs like trials, spiral hypertension, off and on medications, patients with uncontrolled hypertension, patients with elevated cardiovascular risk, patients with non-adherent to medications, drug intolerance, who want renal, patient preference is an important choice for some patients, and finally, patient defined by guidelines. Thank you for your attention.
Thank you very much, Dr. Magdy, for the excellent explanation of most of the recent trials. As you know, I started the first case of denervation 12 years ago in a live session in the Egyptian Society of Cardiology. And at that time, there was a big wave of support of such a procedure. Finally, after various studies and after the sham procedure in the USA cases, they abandoned the procedure again, and it died for a little bit. I think what we knew recently that the renal nerves are not at the ostium mainly, because we were taught that we have to denervate the ostium, which is the highest load of denervation, and don't go peripheral. Now we are doing the reverse. You have to go peripheral, not ostial, and as you showed us elegantly that there are some nerves that bypass the ostium and goes directly to the branches. So my question would be, you pointed out that it's a resistant hypertension. So my question is how to define resistant hypertension, if you're going to use it, and does the future hold that it could be a cure for hypertension, such a procedure, and if it's started early in a young age? What are your thoughts about that?
Yeah, nowadays we have many new studies for renal denervation, and many questions have been raised regarding which is the ideal patients who should be referred for this procedure. And the resistant hypertension, regarding the first question, which was defined in these trials, systolic blood pressure more than 150 millimeter mercury despite using of 3 medications including diuretic. This is the definition for enrolling patients up to 180 millimeter mercury systolic. This is the inclusion criteria for spiral hypertension off and on medication. And interestingly also in these trials, they included patients with mild to moderate hypertension who are intolerant to medications, who prefer the procedure or non-adherent to the medications, which are common. So increased sympathetic activity is very important, because a heart rate, for example, can identify patients who are good candidates for this procedure, because increased heart rate indicates increased sympathetic activity. So the selection of patients is not easy. You have to properly select the patients who should be considered a good candidate for this procedure, not for every patient with hypertension, because we cannot recommend the procedure for any patient with hypertension. We have to start the medical treatment, and after titrated medical treatment, we have to encourage the adherence to therapy, and we have to assess if the patient is taking the drugs or not. So this is not easy, and we have to collaborate with hypertension clinics, because the referral of those patients are coming from the hypertension clinics, patients well known to take the medications or not. So it's a great challenging topic.
Well, thank you, Dr. Magdy.
Any comments from the chairmen, if you have any comments or questions?
Okay, can you hear me?
Yeah, we can hear you.
Can you hear me?
Go ahead.
An overview of this topic that I believe is
we can hear you, we can see you now also. Okay.
Will be the wave of the future. I think this will be ultimately the wave of the future, but I think we still have some obstacles during the procedure. We need to have criteria to determine the definition of a successful ablation of the renal nerves. Until this moment, we still do not have criteria during the procedure to guide us when to stop and say, okay, I have done a good job, I am satisfied. I think this is very, very important.
Yeah, I think the most important is that to have some maybe blood investigation or something that tells you that you succeeded in denervating all the nerves. I don't know what to do, because this search has been now for over 15 years and we don't have an exact marker of success. Okay, you do the ablation and you go peripheral and you do everything that needed to be done, but still you are not sure that will be a good long-term result. We hope that one day we'll have a marker or something that tell us when this marker goes down, like BNP for heart failure, NT-proBNP, then you have succeeded and you are assuming a good result. Is there in the future some marker?
Yeah, now there is a ongoing studies looking for predictors of success, and how can you know that after the procedure is well and the patients will benefit. So stimulation programs now studies stimulation before and after radiofrequency ablation. Renin activity level may be a marker because renin level will decrease after this procedure, so could be considered a biomarker for the success of the procedure. And on the table, heart rate reduction. Heart rate reduction indicates that you did a good procedure for interrupting the increased sympathetic activity. So all these biomarkers or clinical heart rate or stimulation techniques before and after, we don't know in the future, maybe another predictors may be seen.
Okay, I think we are late in time, so we'll proceed with the session. Dr. Magdy, please introduce our.
So now allow me to welcome our distinguished EC faculty today, Professor David Cabudano, Associate Professor of Cardiology at the University of Catania, Italy, Chair of the Scientific Documents and Initiatives Committee of the EPCI, Co-Director of the PCR, Editor-in-Chief of Euro-Intervention, Associate Editor of the European Heart Journal, Editorial Consultant of JACC Intervention, Section Editor of Thrombosis and Hemostasis and Clinical Research Course, and Associate Director of ECT. We are delighted that you are joining us today. Thank you very much for accepting the invitation, Professor David. The floor is yours. Go ahead.
Thank you, Professor Abdelhamid. And actually, I have to thank you for the invitation and congratulations for pioneering this concept of hybrid congresses in the era of the pandemic. I think it's very nice and lively that we have a live part and people from remote. So congratulations, it's very enjoyable. So my topic today, it's a tricky one. It's a controversial one. 2020 state-of-the-art on left main disease intervention. You know that in social media and outside and beyond, there is a lot of debate about this topic once again, fueled by the debate that started after the presentation of the 5-year results of the Excel trial. But let's go step by step. So this is my disclosure of financial interests, nothing really specific to this topic. So if you look at the timeline of the different trials that have been published on the topic of revascularization for left main disease, you recognize many familiar names, Syntax, Pre-Combat. Over time, these trials have also published their extension of follow-up. Noble and Excel were published in 2016, and then in 2019 we had the 10-year results of Syntax. The trial is called Syntax Extension, Syntaxes, and we have Excel 5 years to 2019, and recently we have seen in 2020 the 10-year results of Pre-Combat. So let's see how the guidelines have changed over time based on these results. At the very beginning, 2005, we had the ESC guidelines for PCI, and at that time, I remind you that PCI was considered, in the absence of other options, as a 2B level of evidence C, because there were basically no data. And then, of course, all the trials, but in 2010, after Le Mans and Syntax, we see things getting more complicated. So CABG is 1A, and I remind you that these were the first guidelines that were joint between the ESC and the European Association for Cardiothoracic Surgery. So CABG was 1A, regardless of the risk and the number of vessels involved. PCI was recommended as a 2A if it was left main isolated or left main plus one vessel, and the location was the ostium or the shaft of the left main. Otherwise, if the location was the distal bifurcation, then PCI was 2B, level of evidence B. It was 2B also for patients with the left main plus 2 or 3 vessel, but a SINTA score less than 33. And finally, patients were excluded from PCI if they had a 2 or 3 vessel disease and a SINTA score of at least 33. So that was the situation in 2010. And then we have seen Pre-Combat, we have seen a study from Germany, from Boudreau. We saw the results of Syntax at 5 years. And then in 2014, a new iteration of the guidelines, again, CABG class 1B, and it was somehow simplified, so there was no mention of the number of vessels on top of the left main and the location of the plaque, but everything was about the SINTA score at that time. So SINTA score less than 23, class 1B for PCI, so for the first time, at least one portion of the patients were recommended as class 1. Then we have 2A for PCI syntax between 23 and 32, and then class 3 again for patients with SINTA score more than 32. And basically this is not the end, because in 2018 we had a new guidance for revascularization. Again, it was joint between ESC and EICPS, and it was a copy and paste of the recommendation from 2014, so there was no major change. So what next? Basically now we have some new data on long-term follow-up of the comparison between the two procedures, and it seems that it's not ended, and actually this guidance, this is something that has been already announced, will be revised in 2021. So the question is why? Let me go into the Excel controversy, because I think this is very relevant to this discussion, and perhaps the big story of 20 if we talk about the left main. So just as a reminder in this kind of timeline, remember that the Excel trial recruitment began in September 2010, and then in July 2011, Eurointervention publishes the Excel protocol. So it is very important that we look at these details in order to understand why the story evolved in that way. If you look at the protocol of Excel as published in Eurointervention, basically, the author said that the primary endpoint of the trial would be assessed at a median of at least 3 years, with all patients having at least 2 years of follow-up. And the primary endpoint was composite of all-cause mortality, myocardial infarction, or stroke. So the point is that myocardial infarction was defined according to the protocol, of course. And we will see this definition in a minute. But remember also that the authors, and this is important again for this discussion, mentioned that the secondary endpoints dealing with myocardial infarction would have been a protocol-defined MI, and then divided into periprocedural or spontaneous, and Q-wave or non-Q-wave. But they also said at that time, already in 2016, that the MI would have been adjudicated also per the universal MI definition. So what was the definition of MI in the protocol of Excel? So basically for post-procedural MI, periprocedural MI, the assessment was within 72 hours, and in order to qualify for this outcome, the patient had to have CK-MB increased by 10 times or 5 times in the presence of EKG, angiographic or imaging criteria. So that was the protocol. And the spontaneous MI was defined as something as a rise and fall in CK-MB or troponin 1 time plus EKG, angiographic or imaging criteria. So protocol defined MI was defined as such, and soon after, and soon means 2 years actually, there was the publication of the SKY definition of myocardial infarction. And that is interesting also to note, because the SKY definition is quite similar to the definition of the Excel trial, because basically they define post-procedural MI, and this definition is valid for patients with normal values after both PCI and CABG, so elective patients within 48 hours, and they defined again post-procedural MI as a CK-MB of 10 times or CK-MB of 5 times plus EKG criteria. And they may look small details, but the small details matter in this story. They also said that if you do not have CK-MB, you can consider cardiac troponin, but then in that case, you need a large increase in biomarkers, at least 70 times, or cardiac troponin can increase 35 times, but in the presence of EKG criteria. So the SKY definition was very similar to the definition of the Excel protocol, and you see that basically it's based on biomarkers, and sometimes you can accept a lower threshold for biomarkers provided that you have at least EKG criteria. So this definition is very different from the universal definition. So the universal definition was published in 2012, and basically the authors of the Excel mentioned that in the protocol as a secondary outcome. So I remind you that in the universal definition, the post-procedural MI is assessed within 48 hours for PCI as a cardiac troponin at least 5 times higher, plus symptoms, plus EKG, plus angiographic or imaging criteria. So what you see here, the difference is that you have, first of all, some enrichment factors beyond the threshold of biomarkers. You have also symptoms, EKG, and angiographic or imaging criteria that need to enter in the discussion. And then the other important point is that they use troponin as a first option rather than CK&B as the first option. And also, differently, they separate the definition based on PCI or CABG. So while in the SKY definition, PCI and CABG have both the same definition, here it is different, and there are different thresholds for PCI, periprocedural MI, and CABG. So for PCI 5 times, and for CABG you need a higher increase in troponin because surgery has cardiac manipulation, of course, so you may predict that there will be a higher increase in biomarkers, and this doesn't necessarily translate into higher injury to the heart. But you see that basically here the threshold was 10 times plus symptoms plus EKG, angiographic or imaging criteria. So we have all the ingredients to understand what happened next and why this was so debated. In 2016, the 3-year results of Excel were published, and you may remember the results that basically showed a primary endpoint of 15.4% of death, MI, and stroke in the PCI group and 14.7% in the CABG group. So the trial was powered for non-inferiority at 3 years, and the P for non-inferiority was 0.02, meaning that non-inferiority was met. Then, looking at superiority, there was no difference whatsoever between the two groups. Looking at the different secondary outcomes in the trial, there was actually a decrease in periprocedural myocardial infarction, according to the protocol definition, in the PCI group, or if you want, an increase in periprocedural myocardial infarction in the CABG group, and that was statistically significant. However, there was no reporting of the universal definition, which was different from what was announced in the protocol in neurointervention. And you see also that there was, as usual, I must say, an increase in repeat revascularization with PCI as compared with CABG. But basically, there was not too much discussion at that time, and the conclusion was that death, MI, stroke was similar between the two groups, and PCI was non-inferior to CABG. So after 2 years or less, there was the publication of the guidelines, and I have already shown you the results that for the first time for the second time actually, because it was already in 2014, confirmed that PCI is class 1 for at least one proportion of patients with the lower SINTA score. Then in September 2019, and we go basically to a few days ago, let's say it's 1 year ago only, we have Excel 5-year outcomes published. And here the things are a little bit different at 5 years, because you see that in terms of the primary outcome, we have rates that are not so different, and the odds ratio is neutral. But here it's difficult to interpret, because if you use a non-inferiority test, you end up with one interpretation. If you use a superiority test, you conclude that there is no difference. But it's more interesting to look at the secondary outcomes. That was increased with PCI. And of course, you may question that this was not cardiovascular death, it was mostly non-cardiovascular death. But we know that it's difficult to adjudicate, of course, the reason for death, and so that from any cause is an important endpoint. And here it was increased with PCI. You see here the definition of MI, again the protocol definition. There was an increase in periprocedural MI with CABG, once again, of course no change because this is a longer term follow-up, but there was an increase in spontaneous myocardial infarction with PCI, so the other way around. Again, there was no reporting of the universal definition, no difference in stroke, and again an increase in ischemia-driven revascularization with PCI. Meanwhile, we also have the final 5-year outcomes of the Noble trial that shows an increase in MACE, in MACE actually, with PCI, 28% versus 19%. But here the endpoint was not only death, MI, or stroke, but it was also including repeat revascularization, and MI excluded the periprocedural MI. The authors reported again the non-periprocedural MI, so the spontaneous myocardial infarction, which was once again increased with PCI, and total repeat revascularization was increased with PCI as well. So the Noble trial was not positive for PCI, or not as positive as the Excel seemed at the very beginning. So now the controversy starts, because after 1 month there was the EICTS, and here a prominent surgeon who was also part of the surgical leadership of the Excel trial, David Taggart, complained officially that, well, you see his words, what happened in Excel was a disgrace, that halfway through the trial the definition of myocardial infarction was changed. I believe the data was manipulated using a changed definition of myocardial infarction to try to prove for the composite endpoint that there was no difference. So an important accusation here, because it says that the use of the definition by protocol of myocardial infarction changed the fate of the trial and the overall interpretation. And basically he complained because the universal definition was not used here. So soon after, 1 month later, there was a BBC investigation that also reported some leaked 3-year data from the trial using this time the missing definition, the universal definition. And here the journalist Deborah Cohen said that the research team used an unusual definition of a heart attack, but that said that they would also publish data for the more common universal definition of a heart attack alongside it. And the name of the program was Newsnight, and they have seen that the unpublished data, and this data for the journalists shows that under the universal definition, patients in the trial that had received stents had 80% more heart attack than those who had open heart surgery. So even a bigger accusation at this time. 1 month later, the EICTS withdrew the support for the myocardial revascularization guidelines, and that's of course very important to note, because so far the guidelines have been, of course, the guidelines of the ART team. So the surgeons do not agree with the content of the guidelines. It's a serious thing, of course. And in July 2020, so more recently, the Excel investigators have replied to some letters that have been sent to the New England Journal asking for the universal definition of myocardial infarction data. And finally, in September, they also published a paper that reports in full the procedural MI analysis from the Excel trial. And these are the results, which are very interesting, I believe, because what you see here at the very left is the result of the trial with the protocol definition. We are talking about periprocedural MI, basically. If you look at the second sets of charts, you see the results with the third universal definition using only CK and B. And here you have opposite results. Here PCI is worse. If we use a mixed definition that uses CK and B and troponin when you add it, then you see that it's the same. PCI is worse. If we look at the troponin cohort, so only patients who have troponin, because one of the explanations that the authors gave was that troponin was not routinely collected, you see the same pattern. If you use the protocol definition, PCI is better. If you use another definition with troponin, it's the other way around, although here it's not formally significant. So it's a matter of the definition you use. And they also reported the results of the trial based on the different definitions. And you see here the protocol-defined MI, so no difference as we have seen. But if you use the other definition, the results of the trial change, and PCI is worse as compared with CABG, both at 3-year and at 5-year. So that's why this is very controversial. And in fact, the latest news is in October, the ESC and the EICTS have announced the review of the left main guidelines, and hopefully this will lead to new guidelines and hopefully the end of this controversy for the sake of patients and all the physicians involved in 2021. So I would like to conclude by saying that whatever the indication, of course, there are patients who can be treated only with PCI, patients who can be treated only with CABG, and patients who can be treated with both. But when the indication is decided by the art team, it's important to excel, meaning that for PCI you should use established techniques that improve the outcomes as much as possible. So IVUS guidance, if you can, we have listened to a beautiful presentation on bifurcations that showed the pros and cons of the provisional and the DK crush technique. Of course, you should use an appropriately sized drug-eluting stent. For the CABG, there are also good standards, such as using arterial graft, epiaortic ultrasound, and now it's used more and more to avoid stroke, transesophageal ultrasound. And on top of that, both techniques should use the art team discussion as a way to get the best indication. They should target complete revascularization. They should use optimal medical therapy on top of the revascularization technique. So in conclusion, left main disease intervention in 2020, I would say that decision-making for left main disease should be informed by the best available evidence and based on the recommendation of the art team. For patients with left main disease who are amenable to both PCI and CABG, the 5-year results of the EXCEL and NOBLE trial suggest that CABG reduces MI and repeat revascularization. In EXCEL, CABG also reduces all-cause mortality. The ESC and the EICTS are currently reviewing the evidence of revascularization for left main disease to issue updated recommendations, hopefully in 2021. Thank you very much for your attention.
Thank you very much, Professor David, for this elegant presentation. I will start by just a question regarding IVUS guided left main versus no IVUS. Is it important in every case to do an IVUS or not? The impact of using IVUS on the outcome, short term and long term. The second question regarding the platelet reactivity in left main intervention for patients with low residual platelet activity and the risk for stent thrombosis in left main intervention. Do you have any data regarding this issue?
Okay, so for the IVUS, yes, we have good criteria and good cutoff for the use of IVUS to optimize the procedure. And basically, we have also recent data from the TCT Connect with the ultimate trial that shows that the IVUS actually improved the outcomes. So I would say yes. And of course, experienced interventionist knows that when you have IVUS, the action is to post-dilate the stent. So many, of course, say, okay, I will post-dilate anyway, I don't need IVUS. But there are so many information in using IVUS, not only after the stent, but also before the stent, that I tend to use it every time I have a left main disease, I must say. And regarding the second question on platelet reactivity, so basically the evidence is against the use of platelet function tests because there is no demonstration that they really change the outcomes. On a case-by-case basis, in situations life-threatening like left main disease, I can understand that someone feel better if we know the platelet reactivity of that patient. The only setting where it's proven that platelet function test is helpful is de-escalation. So basically in the ACS domain, you can use that to know whether the patient is responsive to clopidogrel, and in that case, upscale to prasugrel. So this is the only indication in the European guidelines for the platelet function testing. But on a case-by-case basis, I agree that everything is plausible.
Well, thank you, Professor Capodanno. Yeah, any other question from the panelists, please?
Can you hear me?
Yes.
Can you hear me?
Yes, yes, Ayman. Go ahead, please.
Okay. Thank you, Dr. That was a wonderful timeline of all the events regarding left main in such a short period of time. I have two comments. First of all, regarding the universal definition that was originally chosen for the trial, that was a definition that actually arbitrary. It has never been validated in any study to prove that it actually can predict long-term events. They changed the definition later into the SKY definition, and that was what they said was that it was validated in the study by Yuri Oren Ben Yehud. and that the paper that they published before showed a correlation between that definition and subsequent events. So it makes sense to change, and it's not the first time that our definitions change before the results come out. As a matter of fact, in the ischemia trial, I'm sure this was recent, and we all remember how Greg Stone was attacked like 7 months or 6 months before the results came up, and they accused him of changing the definition. But then after the results of the ischemia trial came out, nobody mentioned it anymore. So I would like your feedback on this one.
Yeah, it's really, I agree with you, Ayman, and it's all about the definition. If you choose one or the other, the results of the trial dramatically change. That's very important. And I have no preference, actually. So from my standpoint, I think the procedures are very different in terms of the troponins that they release. So I can understand the argument of the surgeons that say you cannot use the same cutoff. At the same time, it's useful that we separate myocardial injury from myocardial infarction, so you need something clinical on top of it. It's also true what you said, that the validation is for the other one, the SCAI definition somehow, because it is shown that if you have a very high level of troponins, this correlates with that, otherwise no. I like the conclusion of the editorial to the JACC paper that I've shown by Donald Catlick that says, if this is too much controversial, let's think of a trial and remove the periprocedural MI from any definition of combined endpoint. Let's concentrate on something else, which probably is the only way to move forward until we have a better definition.
Please,
I
Professor Raghi.
And I think we have a major issue with troponin. I think troponin is just unreliable, frankly. Anyway, that's another topic for discussion.
David, thank you very much, Dr. Capodanno. This was absolutely brilliant, and it's very, very important because those of us on Twitter have been following the controversy, but actually, let me assure you that for many who heard you tonight, this is new. They were not even aware of the controversy. My question is about using markers in real life. I mean, in non-STEMI, non-acute coronary syndrome left main, I mean, most of the left main patients we do are actually stable patients. How many of us actually do a troponin pre-procedure and then post-procedure? And how many of the surgeons who are taking a totally stable left main patients do a troponin the day before the bypass and the day after the bypass? I mean, I don't think that in real life this definition means a lot to either operators or patients. Of course, having said that, if the patient has chest pain or ST changes, that's a totally different story. But just out of curiosity, because that doesn't happen routinely in Egypt, do all patients in Catania going to have a bypass or a left main PCI undergo a troponin the day before the procedure?
So before the procedure, no, but after the procedure they do, and I can tell you that I disagree that this is done, because I totally agree with you. It's not actionable at all. So whenever you find an increase in troponin or whatever, and the patient is fine, you do not go to the cath lab again to look at the stent. So there is no point in measuring it. So every time I see that we wait for the discharge, etc., because we have a new troponin draw, I always think, okay, but if this is a little bit changed, what will we do? Nothing, probably. So what dictated the rush to the cath lab or the emergency department again, or the emergency room, is the chest pain, is the modification of EKG, a new loss of viability of the echo. But the markers by themselves, maybe we agree, they don't tell us all the story. I agree with you.
Well, Professor Capodanno, the last question is, do you think there is a place for a hybrid procedure in the guidelines?
Oh, definitely, yes. And I think probably the reason why it's not in the guidelines is simply that there is no much evidence, only evidence from small trials supporting it. But the concept is so smart in my mind, because a mammary artery is something great for a patient, but maybe DES are more competitive versus a saphenous vein graft. So the idea of having the best of both worlds makes a lot of sense, and I really hope that this ARC team will join together and work together in order to get the best of the techniques for the individual patients.
Thank you very much, Professor David. We enjoyed too much with your excellent presentation, and thank you very much for accepting the invitation, and see you sooner in Egypt when life comes back to normal. Thank you very much for joining us today.
Thank you. Thank you very much.
Thank you. Thank you, Professor Hani. Thank you, Professor Ayman. Thank you, Professor Sobhi, Professor Adel Atrebi, Professor Ahmed Al-Gharid. Thank you very much. Now we will close this session. And this is the end of the first day of cardiology updates. And tomorrow we have two interesting sessions. One session for non-STEMI guidelines, and the second session is heart failure. And we have distinguished faculty from the EC in the two sessions tomorrow. Thank you for the attendees. See you tomorrow. Bye.